Well, good morning, everyone. We'll go ahead and get started. We had a great day yesterday, led by Mike Sag and the team, taking us through antiretroviral therapy, STIs, and a number of exciting topics, including mRNA and the next generation therapies. Well, today we're going to shift gears and focus on a combination of viral hepatitis and the liver, talking about hepatitis B, C, D, and fatty liver disease, which is a growing topic in people with HIV. So welcome, and welcome to our audience who's joining us virtually as well. I'm Mark Solkowski from Johns Hopkins. Like Dr. Sag, I've had the opportunity to be here since it was in the late 1990s, perhaps not the first, but somewhere in the single digits for sure of OPMANs. As I already mentioned, this is a hybrid conference. We're really thrilled to have you join us here in person. I think as we learned yesterday, and the energy that you get in person is really a very important aspect of what we do. But we're also very happy to have you join us virtually. We keep the questions coming in, send them in all morning long, and we're happy to answer those as we go. So we have a hybrid conference, and we're happy to welcome you all. Just like yesterday, today's will be accredited. There is both in-person credits as virtual credits. The difference there is the difference between the round tables. So in-person people rewarded, as we'll talk about, with the opportunity to attend some round tables in the early afternoon with our faculty. We do anticipate there'll be some opinions given. In fact, that's what we like about the OPMAN conference. We want to hear opinions about how we should be managing our patients. The theme I like to think about is, what should we do on Monday morning when we go back in to see patients in clinic? Are there some tidbits we can take back from here, some things we can apply in practice? That's the optimal management in OPMAN. There will be also some off-label discussion, and that's also what we want to see forward thinking for a number of our topics as well. We are grateful for our commercial supporters. Of course, there is a registration fee for everyone to attend, but we're really thankful that we have independent educational grants for our supporters that allow us to put on really such a top-notch program and to stream it with professional quality across the world. There is a paper brochure that is available in person. It's got the hotel map and other things. I have to say, if you haven't figured out the hotel map by today, you're probably in a bit of trouble, but it's in there as well. At home, of course, you don't have a paper brochure on site, but you do have a virtual brochure. There is a place to click. Now, I'll warn you that we've had to alter the timing of the talks today. Every talk you see listed will be given, but we changed the order a little bit. So those of you at home, we couldn't update the virtual PDF of the program, so bear with us as we jump around a little bit. I'll go through that in a minute. The in-person presentation slides, they were sent to email with access to the day 2 slides. Those of you who are trying to get real extra credit probably went through those last night, are already up to date asking your questions. But you do have access to those slides, and for those of you joining virtually, can click on the topic and see the slides as well. There's the place to log on screen to look at the presentation slides. They're on the agenda. Technical assistance. So we do have someone standing by chat or phone. The phone number is listed here, and there's a button for those of you joining virtually. In person, we're happy to help. Just raise your hand or head to the back, and we'll be happy to take care of any technical problems. We will be using the audience response questions, so a little bit of tech goes in there, but we had all day yesterday to practice that. So the conference is being recorded, both audio and visual. Because of that, we want you to silence your cell phones. We want you also to hold your questions till the end. I guess that's one advantage of joining virtually. You don't have to silence your cell phone. You can pretty much do whatever you want, and we won't know about that. But here in the room, the cell phones are disruptive. ARS, I mentioned this already. You can either scan this code, but you also note in the middle of your table is the same code, the QRS code that you can access the poll. You can use your phone, or you can use the computer to answer the ARS questions, and we'll go through many of those today in both the talks as well as some cases. The post-conference evaluations for CME and CE credit, you'll be emailed an online survey, and you'll get reminder emails up to 5 days until completed. What I would advise is just go ahead and answer that first email you get from Megan. Go ahead and give us your survey. It really is important. We will gather in the coming weeks to review all of the feedback. If you use those fields where you can type in talks you want to hear, what you like, what you didn't like, we go through that. So please do your online survey. And if you want your inbox to remain free of additional emails from Megan, go ahead and answer the first one. Long-term outcome measurements, also important. You know, as I mentioned earlier, the goal really is to take home management strategies, things that will change your practice or influence your practice. And we want to assess that with what we call long-term outcome measures. So we'll get another survey about 2 or 3 months after the conference, and it really is important to see what stuck and what you thought was really valuable. This feedback, again, is really important. We do look at it, we do take into account, we debate it, and as we think about the next year's program. So there is an archive. The video archive is available will be available in early April, and you'll be able to refer colleagues if they want to watch some of this, or you can go back on your spare time and watch your favorite segment from OPMAN 31. So the Sunday agenda, we've already, as I mentioned, we've got a few alterations to this. I'll go through those, but we're doing the introduction now. Our first talk will be from Susanna Nagy from Duke University. We'll talk about hepatitis C. Jordan Fell from Toronto will talk about hepatitis B. And then we're actually going to jump ahead. Debica will join us at 11:20, thanks to the airlines. I won't name the airline, but one of the airlines decided that her flight should not fly, altering the schedule. So we've got her a little bit later in the morning, and we appreciate her navigating the airways to get here. So she'll talk a bit later, and you'll hear from Ken Sherman from the University of Cincinnati, who will talk about Delta and a re-emerging pathogen. Then we'll move to have Jordan Lake talk about HIV, obesity, and metabolic-associated fatty liver disease. And Glenn Treisman will talk about managing mental health of healthcare providers, what we think of as burnout. I think a really important lecture, a really important topic to cover. We look forward to Glenn joining us. We'll have breaks and panel questions as we typically do. So send your questions in virtually all the time, and we've got microphones here in person. We do have case presentations. We'll ask our faculty to join us. We'll go through those, and then we'll get to in the early afternoon, the faculty roundtables. We're going to do it like we did yesterday, where we're going to ask people to join 2 of the sessions. There are 4, and we'll ask you to join 2 of them for 30 minutes. We'll have a break, and then we'll switch it again. We got some feedback that people wanted to attend more than one, so this allows us to try to get as many in as possible. You won't be able to attend them all, but pick 2 of your favorites. These are the breakout sessions. We've got challenging cases of hepatitis C, hepatitis B and D. We've got fatty liver disease, and we've got substance use disorder. The names you see there are the rooms they're located in the hotel. And unfortunately for the virtual attendees, we've not mastered the ability to stream these roundtables quite yet. So this is for in-person attendees. That's a plug for next year. If you want the small roundtable learning, sign up and come in person. So with those introductory comments, I'm really thrilled to kick off day 2 of OPMAN 31 and invite Dr. Susanna Nagy, who's a professor of medicine at Duke University. I promise not to give you all of her titles, and she will talk to us about hepatitis C elimination. Where there's a will, there's a way. Susanna?
It is great to be back. It's great to see everyone this morning. So as you can see from the title slide, we're going to be talking about HCV elimination. And I think importantly for the folks in this room, making folks aware of the White House's rollout of a plan for elimination and the role I think that we will all play as healthcare providers in a path to elimination for HCV in the United States. These are my disclosure slides. So we're gonna, as we talk through the concept of elimination and really try to track with the current, what we know currently that the White House is saying regarding their plan for elimination, we'll talk a little bit about epidemiology, really focusing on what are some of the things that we need to change to get to a path to elimination from what we've been doing in our clinics to date, and then what is the plan that the White House is rolling out. So again, you know, the first that I heard of a White House plan for a national plan for HCV elimination was actually at the American Association for the Study of Liver Disease conference in November, when Francis Collins, who many of you would know from the NIH, who is now a scientific advisor for the White House, came to the meeting to talk about the fact that the White House and the federal government is finally putting together a true plan for elimination. And it is my understanding that there are billions of dollars in the current White House budget to move this plan forward. And I think if that's going to happen, then providers on the ground are going to need to be aware of how we begin to adapt to respond to this and engage in this, because it's not going to happen if folks in this room are not doing part of that work. That's what it's going to depend on, all of us as healthcare providers. So I want to talk about this just in the context of the WHO, right? Targets for elimination, where we are, and what are in this country, in the United States, what are the issues that we are going to be up against to actually be able to achieve this? So you have seen this, I think, from me many times in some way, shape, or form. These are the WHO targets. You can see for 2030, and then in parentheses for 2020. The WHO targets focus on diagnosis. So how many patients who carry this infection have been diagnosed? How many of those patients actually get access to treatment? Can, in that, you reduce the incidence of this infection, and can you reduce mortality? And what I will say is that we know that 2 of these have been heavily impacted by the pandemic: diagnosis, HCV testing, and then ultimately transitioning to care. We do know that, likely driven largely by where we are with access to DAAs to date, we have seen a decrease in the mortality related to HCV and liver disease. But we also know that we have long ago fallen off the curve as it relates to incidence. And I think, and then again, as I mentioned, further falling off the curve, in particular because of COVID-19, and really a lack of uptake of universal screening for patients living with HCV. I think everyone in this room is probably aware that that issue that we are struggling with incidence is going to continue to be a major issue for us if we do not get to some of our highest risk patients. We know that we have continued increases of acute hepatitis C in this country. We know that this is largely driven by our younger generation, and I'll talk about that. But you can see over the course of this study a 400% increase, and this is largely driven by patients between the ages of 20 and 40. These are largely young people who are transitioning from opioid addiction to injection drug use, and this is something that we are absolutely going to have to get a handle on if we're going to be able to achieve HCV elimination. And we'll talk about what that might look like for us as medical providers. Again, I think many of you are used to seeing, you know, the kind of concept that we always talked about of the baby boomer generation, the social generations as we refer to them, really being a primary driver. And this was true when I was in my training and we talked about, you know, the concept of baby boomer screening. But what we see now is that this younger generation, the millennial social generation, has overcome the baby boomer population in terms of cases of chronic hepatitis C. And you can also see that there is some difference in women in the differences of these generations. And this actually plays out to be critically important when we think that many of these young women are able to get pregnant and are at risk. In fact, what we are seeing is higher risk of transmitting this to the baby. And that is actually critically important for us as we think about how we navigate this. We now know that there are 2.4 million people in this country living with chronic hepatitis C, and that 40% continue to be unaware of their infection. So, challenges to elimination. I'm going to talk a little bit about history, and then we'll talk about where we are and where we need to go. I mean, as we'll talk about in the next slide, one of the major limitations has always been that we, for a long time, use risk-based screening. We ask patients in our clinics, have you done this? Have you done this? Have you done this? And what we know is that that was woefully inadequate to actually get to a diagnosis of the majority of people living with hepatitis C. We'll talk about this. We're now at a universal screening recommendation for quite some time. Hopefully that is slowly changing where we are. We still continue to struggle with complex testing algorithms, so we still need 2 tests to be able to determine whether or not, or differentiate someone who's been exposed to hepatitis C from someone who's actively infected from hepatitis C. This, we will talk about, is a major challenge for us as we talk about how we need to simplify access to HCV therapies, how we need to get to a test and treat strategy, a rapid startup concept, something that we can do in HIV, but we cannot do at this point in hepatitis C. You know, historically, we had very complex, low efficacy, and very poorly tolerated therapies. We now have direct-acting antivirals, but as you all know, for a period of time, and frankly, even today, they continue to be costly, which continues to be a barrier for us. And we're going to talk about what the White House is saying about how they want to address that. And then we all know that we lack effective preventative strategies. We lack a vaccine. We actually do have a lot of preventative strategies that can work, as we know. Needle exchange, needle syringe exchanges, making sure people have safe and appropriate equipment and are in have safe places to go. We also know that state by state, the level of access to those things is not equal. So I will say, and I think folks here know this, universal screening has been a thing for a long time. You know, I think as an infectious diseases provider, I was really proud that the IDSA worked very closely with the AASLD to be the first group to make this recommendation for universal screening. This was then followed by the USPSTF, the CDC, and then ultimately, as I mentioned, because of these young women who are part of this new millennial epidemic, really making sure that the societies for obstetrics and gynecology really are on board to make this recommendation for testing and screening in women, because for many young women, their primary and sometimes only access to health care is at the time that they are pregnant. So let's talk quickly about diagnostics. I think this continues to be a major limitation for us. Right now, as I mentioned, we have a 2-step process. An HCV antibody says that you've been exposed. It does not mean that you are actively infected. And that HCV antibody generally is positive for life. So, you know, people can be re-exposed, particularly in our highest risk populations. You still need that HCV RNA or another test like an antigen that actually tells you someone is actively infected. What we know is that in order to do what we need to do, like I said, test and treat, giving someone drug on site, or being able to go to the patients and the people where they are in needle and syringe exchange sites, at Suboxone clinics, et cetera, we're going to need testing that can be done in real time at those sites. And right now we lack those. And that is going to be a critical step to elimination. What we also know is that there is data, as I highlight here, and it's really largely here in this FARS plot, that shows that if you have access to point-of-care Hep C testing to determine that you are chronically infected, you are more likely to receive HCV therapy. So this is proven. We know this is the case. What I will say also is that the FDA recognizes this and has recently reclassified HCV diagnostic testing requirements from a regulatory perspective. They have downgraded this, which hopefully, and I think we've learned this from COVID-19 and the critical role that testing and access to testing in-home, point-of-care testing for SARS-CoV-2 was, how critical that was for the pandemic. I think the FDA has recognized this, and they have stepped this down from a class, which will lower the regulatory barrier with the goal of getting point-of-care testing approved more rapidly, recognizing it as a critical piece to achieve elimination. I think another point that we will talk about from the White House plan is going to be about treatment. And again, I don't really see treatment changing much. We can have this debate. I know that there are folks who are really keen to have long-acting HCV agents, which I think would be phenomenal. I would also argue, though, right now, we really do have great therapies. There's no reason to wait for long-acting therapies if they come. Ultimately, right now, we have very safe therapies. And I'm going to show you data that says if you can get pills in the hands of patients, they will take them, and they have a very high chance of achieving cure. And I think that's what we need to do. We need to get to the point that we can really compress the care cascade. We need to do testing, and we need to do access to treatment in a single day, preferably within a couple of hours, to really be able to change this. And just to summarize here, in terms of therapies, we have all oral therapies, we have combination therapies, in a single pill or several pills a day, we can cure patients at 98% with 8 to 12 weeks of therapy. We can cure patients whether they have, regardless of the genotype. You can see that the first all-oral genotype 1 approvals were in 2014. For 2 and 3, it was in 2013. I've lost track of time, but I can tell you that's a decade, right? It's a decade. That's where we are today. And I'll show you some data that says that we really haven't done enough to get access to these therapies for our patients. We can cure patients with end-stage liver disease. We can cure patients who have decompensated liver disease, transplants, kids down to the age of 3. The truth is we can cure patients who have failed other DAA therapies. The only group that's missing here, I would argue, are pregnant women, or pregnant people. And that's still a critical barrier for us right now. So suffice it to say that the guidelines say we should be treating everyone. And so where are we? This was a very interesting study that was recently published in CID that really shows that we have a long way to go. So I mentioned that our first all-oral therapies for genotype 1 were approved in 2014. This is from a very large national pharmacy claims database that shows that we peaked as a nation in prescribing DAAs 1 year after genotype 1 DAA therapies was approved. And since that time, we have continued to decline. Now, did COVID-19 play a role in this drop between 2019 and 2020? Almost certainly. But ultimately, we as providers need to think about ways that we can get our patients increased access to these therapies. Are there disparities in access to these therapies? Yes, there are. You can see here that largely the patients who have been treated to date are from that baby boomer cohort, which is okay, but we really want to not have a disparity in that. We want to be able to see that access to these therapies is true regardless of how old you are. We see disparities based on self-identified race and ethnicity. So if you self-identify as white, you are more likely to get access to therapy. And if you are on commercial health insurance, you are more likely to get access to DAA therapy. That has to change. Just more data to prove that point and to show that regardless of the data that you use, this is actually data from the CDC, looking at patients who are insured between 2019 and 2020, and what were predictors of whether or not those patients who had chronic hepatitis C and were insured got access to therapy. And as you can see here, you're more likely to get access to therapy if you have private insurance, so less likely if you have Medicaid or Medicare. You are less likely to get access if you are in a state where Medicaid was restricted. And you were less likely to get access, in particular, if there were overlapping risk factors for not getting access, like if you self-identified as Black or African American and you were on Medicaid. The other thing that I think is relatively shocking is this data here, that regardless of whether or not what your insurance is, it actually shows that if you are diagnosed with HCV, you are only, this shows you, 15, 20, and 30% likely to get started on HCV therapies within 180 days. I mean, this really shows that there's a significant delay to getting people on therapy, even those who get on therapy. And the question I would ask is why? What is driving that? We really need to be getting people on therapy much more quickly from their diagnosis. So addressing additional challenges. And again, we talk about the care cascade for hepatitis. We talk about the care cascade for HIV. What I will tell you, and I'll show you some data, is one of the biggest drops is really from the point of having a diagnosis or a test and then coming in for that next visit. That is really where you lose a lot of people, which is why I think we need to compress it, right? We need to be able to give people access to treatment at the time of their diagnosis. So again, simplification is going to be key for all of us in our clinics. And I'd love in the Hep C session for those who come to talk about some of the things that we're talking about doing in our clinic to do rapid startups in the hospital. Because we have lots of patients who we try to start as an outpatient and they can't make it in, they end up in the emergency department, they end up in the hospital for totally different reasons. And we are starting a rapid inpatient startup for very high-risk patients that we just can't get back in. And I'd love to talk to you all more about that. But again, to bring home the point, simplified therapies, I think we've summarized this, and just for the sake of time, I'm gonna move through it, but I do think that we have made this complex for so long that it really it's hard to now walk back the things that we no longer need to do to be able to get people on therapy. But what I can tell you is that we have data to say that this can be done. And as I mentioned, we have the therapies that say that this can be done. I think generally, as you know, we are primarily using two therapies, glecaprevir, preventrisvir, which is two targeted therapies in one pill. You take 3 pills with a meal daily, and in 8 weeks, you can achieve a 98% cure. We see that these numbers, even in real-world settings, is well over 90%. And then for sofosbuvir and valpatisvir, these are the two pan-genotypic regimens, so they tend to become the preferred because we recognize that for patients, sometimes getting access to genotype testing can take longer, and the reality is genotype testing really isn't necessary, so many of us have really switched to prefer these pan-genotypic regimens to just take some of those additional barriers away. And again, you can use these drugs in patients, again, with CKD, end-stage renal disease. The real limitation for GP is going to be in patients who have severe liver disease, decompensated liver disease. But beyond that, there are not that many restrictions for me in my clinic. It's largely driven by drug-drug interactions and what medicines they're on. Are they taking a proton pump inhibitor? Those sorts of things are really major drivers for me in my clinic and making decisions of which one to use. But these are all great therapies. They're highly effective. They're very safe when used in the right population as it relates to their liver disease. And again, I think kudos to the ASOD-IDSA guidelines for developing these simplified regimens. If you haven't kind of tried to implement these in your clinical practice, I would highly recommend trying to simplify things as much as you can. I think they provide really nice guidance, both for treatment-naive patients without cirrhosis, but also for patients who have cirrhosis. And again, what are the big differences in these simplified regimens? Primarily driven by patients with cirrhosis need to have hepatocellular carcinoma screening. You need to understand the severity of their liver disease and their liver function by calculating a Child-Pugh score and making sure that these patients don't have kind of what I would call subclinical decompensation, where their risk may be higher. You want to make sure that you're engaging hepatologists in their care. And then remembering that they have a liver disease that after that hepatitis C is gone is going to require ongoing care. But that should not stop folks, in my opinion, from initiating treatment on patients living with cirrhosis. Because again, if we continue to require the referrals to subspecialty care, we're going to miss the opportunity to do one of the most important things, which is to get these patients cured. And then I'm just going to call up the guidelines again. Any guideline members in the house? Debica is on the plane. All right. Can we remove the HIV as someone who's not eligible for simplified treatment, please? All right, so I'm just going to give you some data now that highlights the fact that we can do this and we can do it easily. So MinMon was a very large study. Dr. Solkowski and Dr. Solomon from Johns Hopkins led this study. What this did was take patients who, in many countries, and actually largely was not enrolled in the United States, although I think there was a little bit over 100 patients enrolled in the United States, had patients come into a clinic site. They had some basic lab work. There was no genotype. Patients with an isolated Hep B core were not excluded, only patients with a positive surface antigen. And if you had cirrhosis by FIB4, you were included as long as you didn't have signs of decompensation. You were handed a 12-week supply of sofosbuvir and valpatisvir, and then the site said, we're here if you need any help. We're going to text you a couple times, make sure you're doing okay, but we really want to get you back after you've completed your therapy to make sure you're cured. 95%, right? 95% cure. This can be done. Going to give you a couple of other examples, particularly in some of our higher risk groups, which are the groups that we really need to focus on. I'm going to show you 2 really nice studies. This is a very small pilot study that looked at rapid treatment initiation. This gets to the concept of getting pills in hand. So this is a group that was looking at young people who inject drugs. What they wanted to do was to try to do the concept of a test and treat without being able to do it because we don't have a point of care test, right? But what they did is they took very high risk people who inject drugs who had a known positive hepatitis C antibody. And brought them into the study. They kind of did this usual care thing here, which you can see, like, right, the more boxes, the more complex, the more likely you're going to lose someone. And then what they did here was on day 0, they knew they had a positive hep C antibody. They got their HCV RNA and some additional lab work. They handed them a 7-day pill pack, and they said, don't take this until we call you. Patient goes home. They call them with their HCV RNA. you do have chronic infection, start your pills. And then they came back day 7 to get more pills and to continue in the study. So this shows you confirmed HCV RNAs, and this right here is the difference, right? So if you give them pill in hand, they continue in the care continuum. If you don't give them pill in hand, you lose them, right? This is where we need to do better about simplification and getting patients access. Now, I know in reality, this is something that I would argue if I were talking to the White House right now, would be to say, you've got to deal with the concept of getting access to drugs in same day from a positive test, right? In order to be able to implement this, that's going to be a major barrier that we're going to have to work through, that the federal government's going to have to help us figure out. So another study, again, slightly different. What this study looked at was again in people who inject drugs, single community-based syringe service program in New York, same group doing really phenomenal work. Basically accessible care, low threshold, non-stigmatizing HCV treatment, co-localized in a syringe exchange. You say this is about getting to them, not about them coming to us, right? This is a concept that's really critical to making sure we get to our patients. Versus usual care, which was on-site patient navigation, which is actually more than most of our patients have, but the patient still has to leave that site and go to a place where non-stigmatizing care, feeling safe, may not be something that actually they feel about that place that they're being asked to go to receive their subspecialty care. And again, what you can see, not surprisingly, if you look at this very small care cascade, is that we have drop-off, again, as expected, in that HCV test to engaging and getting access to care. So this, to me, is where we need to focus in the care continuum to make a difference in getting access to our patients with HCV in terms of cure. All right, so how are we going to pay for this? How's the White House going to pay for this? How many of you have Netflix? Right? Netflix, anyone? Yeah, so you are all well aware of the concept of a subscription model, right? You pay once a month, stream all you can, right? And if you pay and you don't stream, that's your problem. That's people, Netflix loves those people. So there's a concept of a subscription model for HCV care, right? First country that did this was Australia. First state in the US to do this was Louisiana. You pay one set price and you win by the more people that you treat, right? So it's not based on numbers of cures, it's based on you get as many cures as you can get done by what you pay for. And what you can see is this for Louisiana was a 5-year model. They wanted to focus on their Medicaid enrolled and people who are in the justice system. And what you can see is they had a significant increase, and this is translated to decreases in HCV infections in their state. Definitely a role model for our government. Yes, it still costs money, and yes, there's still benefit. So what I will tell you is, if you look at the general population in blue versus the population in the justice system in red, if you treat people in the justice system, the greatest benefit is actually to the general population, both in terms of infections averted and overall cost. So we can do well for all of our communities if we focus on particular populations that have the highest risk both of the infection but of onward transmission when they return to their communities. So other benefits of cure, these are simulation models that have been completed and with the investigators and faculty that are engaging with the White House to show that if we actually developed a plan over the next 5 years, we could diagnose over 1 million individuals, we could avert over 10,000 deaths by 2030 and 91,000 by 2050. You can see, right? And we could save $14 billion. This will pay for itself. And frankly, there are very few things that pay for themselves, including puppies. So again, the concept here is one size does not fit all. We are going to have to do this differently. We will not do this in our large academic centers. And for those of you who are not in large academic centers and in smaller practices that are in community-based organizations, the bottom line is this is likely going to be largely done by you. And we need to make sure that we give you the right resources, the right voice, engage you in this process to make sure that we can actually do this. The White House is talking about this, right? They're talking about diagnostic tests, again, accelerating the commercialization of point-of-care testing, They're talking about broad access to curative therapies, and what they're really talking about here, in addition to targeting some of the greatest risk populations and the populations carrying this burden, is talking about doing this through pharmacies, telehealth, community workers, community-based organizations, et cetera. I think this is certainly very exciting that we're finally having this conversation. Our own Dr. Feld is going to be leading a big meeting here with the AASLD and the White House to look at HCV elimination. It's called the HCV Elimination Summit. So I know that we have a lot to do, but I think it's very exciting to finally be having this conversation about HCV elimination. And I hope you all see that there'll be a great role for all of us to play as we move forward with this. All right. Thank you.
Well, great. Well, thank you for that wonderful presentation. And a reminder to those of you both here in the room with us as well as at home, keep the questions coming in. We do have an iPad type device where the questions come in. Now, I will push back on one point that Dr. Nike made. Puppies do pay for themselves. People that own dogs walk more, and therefore that increased physical activity prolongs their lives. So I would push back on the puppy comment about cost effectiveness. Well, with that commentary, we'll discuss more during the Q&A, so save your questions. And I'm really thrilled to invite Dr. Jordan Feld, who's joined us from Toronto, where apparently it's cold this time of year. And Jordan is going to talk to us about management considerations, hepatitis B monoinfection. And, you know, as Susanna pointed out, he is leading a North American Viral Hepatitis Elimination Summit, a really important talk. And maybe during the Q&A, we could discuss where is the national plan for hepatitis B elimination, but we're going to talk more about the practical points of hepatitis B management and get to that in the Q&A. Jordan?
Mike and Mark, for inviting me. It's great to come down here and get away from the Canadian winter for a few days and enjoy a little bit of sun and some learning. And so I'm pleased to be back here this year. And Susanna really gave a very nice overview of how hepatitis C has become so simple. And I'm going to talk about hepatitis B and highlight the fact that unfortunately it's not quite as simple yet, but we're going to focus on some of the areas where there's still some controversy and try to simplify it a little bit. So here are my disclosures. I do a fair bit of research primarily in the viral hepatitis space. So I'm going to go through the current treatment guidelines and talk about our treatment options, and then I'm going to spend most of the time actually talking about areas of controversy, particularly where we think about treating patients that kind of fall through the cracks in the guidelines, the ones that make us scratch our heads in clinic and we're not sure if we should treat them or not, and those are patients with immune-tolerant disease or people with milder immune-active disease. And then I'll spend some time at the end talking about this new idea of actually stopping therapy as a therapeutic strategy. So one of the things that I'm going to highlight to focus on at the beginning is really similar to what Susanna pointed out, that we have a problem right at the beginning of the cascade of care in hepatitis B, that we're just not diagnosing this. So this is looking at data, but you see on the left the situation in the whole world, and you can see that only about 10% of people living with chronic hepatitis B have been diagnosed. But that's not much better here. So even among people who are insured, so this is not including the uninsured population in the US, it's estimated that under 20% have actually been diagnosed. And this has real consequences. We looked at this in our province in Ontario in Canada, and what we saw is that people are, when they're diagnosed very late, this has bad outcomes. So what you see here are people that were diagnosed with hepatitis B within 6 months of having a complication from hepatitis B, namely decompensated cirrhosis or liver cancer. So this is an infection people have been living with for decades, and you can see that almost half, so 44.6% of people were diagnosed with hepatitis B for the first time within 6 months of their diagnosis of cancer or decompensated cirrhosis. And if you stretch that out to 2 years, which is still a very late diagnosis in the terms of their natural history of this disease, you're now up at about 60% of those who develop complications. So this is really a problem. And this is particularly frustrating because just like in hepatitis C, we have very effective therapy for hepatitis B. So much of these complications could be avoided if we were doing a better job. And you can see that really what's driving this is lack of interaction with the healthcare system. So it's people who are older, male, higher alcohol use, and rurality was actually the biggest thing. So people that just don't interact with the healthcare system are people who are more likely to have a late diagnosis. So when we look at the natural history of hepatitis B, unfortunately, it's not like hep C. It's much more complicated, and it's important to remember these phases of hepatitis B when we think about where we're going to put therapy. And so you start out with the immune tolerant period where people have very high levels of virus, but minimal or no inflammation in the liver. At some point, and when that is varies by people, but they will transition to an active phase of disease where they start to have fluctuations in their liver enzymes along with their virus levels. They then go into an e antigen negative phase when they finally clear e antigen, and for some people they will remain inactive over time, but other people will develop more active disease in time. Now, we prioritize treatment really based right now when they have active liver disease. So we really focus on the ALT and the amount of inflammation in the liver as being the driver of this. So we treat people during the e antigen positive immune active phase of the disease. We trend not to treat people who are in this immune control or inactive phase of hepatitis B. In people who have e antigen negative chronic hepatitis B, so they have active replication after clearing e antigen, we do treat these people. And we also treat people to prevent reactivation of hepatitis B when they're getting immunosuppression. So these are really the areas where we do treat. At least for now, the guidelines generally do not recommend treating people who are in that immune tolerant phase or people who are really inactive. And I'm going to talk about these scenarios a little more because there's a little wiggle room, and sometimes it's not quite so clear which phase someone's in. They don't walk into your clinic with a tattoo on their forehead telling you which phase of chronic hepatitis B they're living with, and that can be challenging for us. It's very important to recognize that this is a dynamic condition. So people go back and forth along this continuum, and people need to be followed lifelong when you're managing their hepatitis B to figure out as they transition from one phase to the next. So what do the guidelines say? Well, I'm going to focus primarily on the European and American guidelines. So the AASLD and the European guidelines you see, and they divide them both similarly into e antigen positive and e antigen negative disease. You can see that the thresholds of HBV DNA are slightly different between the two. So you see that here being similar for the e antigen negative, but slightly different for the e antigen positive group. And then the bigger difference actually is in the ALT, where you see that the American guidelines require a twofold increase in the upper limit of normal, whereas the European guidelines focus on just being anything above the upper limit of normal. And I'm going to come back to that because I'll show you some studies suggesting that maybe the AASLD guidelines are a little bit too conservative. And then you can see, and importantly, anybody with cirrhosis, if they've got any detectable HBV DNA in both guidelines, are recommended to be treated. So what are we trying to do with treatment? Well, the good thing about Hep B is it gives us, following the natural history, we can get some ideas about what the goals of therapy are. And you can see that people who have long-term inactive disease actually have very good survival. But it's really the risk of cancer that is driving so much of the global mortality from hepatitis B around the world. And to get rid of the cancer risk, you've really got to get rid of surface antigen. So it's surface antigen clearance is really the key to achieving the optimal outcome in the natural history of hepatitis B. Our current approved therapies are really in two classes. There's PEG interferon and there is the nucleotide analogs. And so there's pros and cons to each of these strategies. I'm going to go through them very quickly. I don't think too many. How many people have prescribed PEG interferon for hepatitis B in the last 5 years? Okay, we have one. So I'm not going to spend too much time talking about interferon. On the nuke side, they're very potent, they're well tolerated, they're oral, but they do require very long or indefinite treatment. And although toxicity seems to be limited when you're giving something for lifelong therapy, you've got to worry about that a little bit more. And there's at least a theoretical risk of resistance, although fortunately it's not a big issue. But it's important to look at how often does it actually achieve our goal of getting to surface antigen loss. And before we think about that, how often does that happen on its own? And so this pooled analysis that came from Indian Wynn's group at Stanford looked at what is the annual rate of clearing hepatitis B surface antigen without treatment. And I just want to highlight that number. It's about 1% per year. So that just happens if you do nothing. So then what happens when you give people treatment? Well, the treatment's very effective at suppressing hepatitis B DNA. So on the left, you see people receiving entecavir. On the right, people receiving tenofovir, are two major high barrier nucleoside-nucleotide analogs. And you can see that almost everybody eventually will get to suppressed HBV DNA. That's good, but it's not clearing surface antigen. What happens in terms of surface antigen clearance? Well, if you look at people, and this is following people who remained in a study and actually continued to take their drug, so-called per protocol analysis. And what you see is in the purple bars, highlighted in red, is you can see that by 7 years, you can see that you were only getting about 12% of people clearing surface antigen. So that's about 1.5% compared to 1% if you do nothing, if you don't treat these people. So it just highlights the fact that the therapy is very good at suppressing DNA, not so good at leading to surface antigen clearance. And it means that this is after 7 years of treatment. You can see that you've really got to be thinking about very long-term therapy. And that's why I'm going to talk about at the end this idea of stopping therapy. And although therapy is very good, it's imperfect. So you can see these are a number of studies that show what is the risk of developing liver cancer in people who are on nucleotide or nucleoside analog therapy compared to those who are not. And what you see is that the risk goes down, but it is not completely eliminated in people who are on therapy. So the important point about that is even when you've put someone on therapy, you've got their HBV DNA undetectable, you have to continue to do HCC surveillance because cancer will still occur, and that is the real driver of mortality in this condition. So in terms of our therapies, we're familiar with entecavir and tenofovir, and most of you are probably now familiar with tenofovir alafenamide, not so new anymore, but this is a slightly safer version of the original TDF or tenofovir, and really the antiviral efficacy of these two drugs pretty much identical, surface antigen and e-antigen clearance really the same with the two drugs. The slight differences are, for reasons that aren't so clear, with TAF you seem to get slightly faster rates of ALT normalization. That's been shown in a number of studies, but the reasons for that aren't so clear. And probably the bigger issue is the safety. So it has a little bit lower risk of renal toxicity and of bone toxicity. So when you would think about using TAF over standard TDF would be in people with a risk of or pre-existing renal or bone disease. This is a group that might benefit from TAF. They could also use entecavir. Or if they've had lamivudine, adefovir, or entecavir resistance, this would also be a group to prioritize it. And you'll hear from Debica later about HIV Hep B co-infection, where TAF has really replaced TDF primarily in most of the tenofovir, including HIV regimens, that this is going to be an area where it's going to be prioritized. Now, what about putting the two therapies that we have together? Would there be any benefit in combining a nuke plus PEG interferon? And again, we see that there's been very low uptake of this, and this is because this study, which was the largest to really look at this, looked at tenofovir with or without interferon for either a lead-in of 16 weeks or for a full year of tenofovir. And you can see that although the combination group did do a little bit better, you can see that they got to 9% surface antigen loss. When you're putting people on a year of interferon for less than 10% surface antigen loss, that's a hard sell. I think as much of a hard sell for providers as it is for patients. So the reality is there's been very little uptake of this strategy and it's not really used. So if you summarize our current therapy, very good at suppressing HBV DNA, normalizes ALT in most people, prevents fibrosis progression, actually promotes fibrosis regression, even in people with cirrhosis, and remarkably, and we shouldn't underestimate this, it prevents and even reverses hepatic decompensation. So you can take someone who walks in your office with ascites, who's bright yellow, put them on therapy and save them from needing a transplant or dying, which is really quite amazing. This is something that was really remarkable with these therapies when they were first developed. Challenges with it, though, are that it reduces but does not eliminate the risk of liver cancer, and unfortunately, very long-term therapy is required because it very rarely leads to surface antigen loss. So when you look at the guidelines, there's general agreement on treating people with active disease, whether they have e-antigen positive or e-antigen negative. There's slight differences in the DNA thresholds I showed you, and then this difference in the threshold of ALT. Both the European and American guidelines recommend treating everyone with cirrhosis. Don't forget that. These are high-risk populations. People that are about to get immunosuppression can go on antiviral therapy, and this can be largely prevented. It's important not to forget to think about therapy in the 3rd trimester of pregnancy for women with a high viral load. And the threshold is an HBV DNA above 200,000 IU per ml. These are generally E antigen positive women, and these are women where you can really reduce the risk of vaccine failure if you put them on tenofovir therapy. But there are a few scenarios where the guidelines don't always there's still some areas of controversy. What should we do with immune-tolerant patients? Should we think about treating them, particularly as they get older? And what about patients with lower-level viremia, particularly if they've got borderline elevation of ALT? And then this question, which I'll pose, is should we actually think about treating everybody? So the pros and cons, we'll start with the immune-tolerant phase of disease. Should we actually think about treating these people? Well, on some level, it makes sense. They've got really high levels of viral replication. There's actually probably a high level of integration of the viral genome into the host genome, which is a cancer risk. They have some transmission risk, both to children and also to sexual partners, and you may prevent silent progression. But the downside is our current therapies aren't so effective. Not sure we can really prevent integration with them. They really have very minimal or no liver disease, even if you biopsy them, and you're probably going to need very long-term therapy in young people. So there's clearly a pro and con to this. And a nice study that came out of Korea that looked at this. They compared people who were in the IT phase, so they had a normal ALT, and they compared them to a group of patients who were immune-active patients, so they had elevated ALT. And interestingly, the immune-active patients, so these are slightly older patients with more active disease, you can see that in both in terms of liver cancer and death or transplant, actually had a lower risk than the people who were in the immune-tolerant phase who were younger. So you would have expected that the IT patients would have done better, and this gives you a hint that maybe actually treatment would have been helpful here. So it's not a randomized trial, but it gives you a hint that maybe treatment would be useful. And when they looked at who was at risk of developing complications in the immune-tolerant group, the biggest driver was age, and the other thing was, interestingly, not higher, but lower HBV DNA. So you can see the group with high HBV DNA actually had the lowest risk. And so what this really suggests is that people who are truly immune tolerant do fine. But it's as they start to transition to immune active disease, where their HBV DNA starts to go down, that you start to see the higher risk of complications. And so would treatment help? Well, the problem is probably not that much. So treatment works to some degree. You can put people, this was a trial done where they gave people 4 years of tenofovir or Truvada, tenofovir plus FTC, and you can see that they suppress some patients, but you can see probably pretty disappointing that with tenofovir therapy for 4 years, only about half the patients had suppressed HBV DNA. Remember, they're starting really, really high, and nobody lost surface antigen. So really not all that effective, and you can see when they stopped therapy, at least some people flared. Now, we did a trial with the Hepatitis B Research Network where we said, well, maybe if we give entecavir and then add in interferon, that's going to work. Unfortunately, no better, so no patients met the primary endpoint for this study, although interestingly, when we stopped the interferon, you can see that they did have some declines in surface antigen that rebounded right back to baseline. So they really went back to this immune-tolerant phenotype, suggesting that they are quite different than patients with more active disease. So should we treat these patients? Well, I think it's important to carefully define the populations. In the true immune-tolerant patients, so these are people with an HBV DNA above 7 logs and a truly normal ALT, for these patients, it looks like the risk of anything bad happening is very low, at least in the short to medium term, so you can follow these patients. But as they start to transition to IA disease, where they've got decreasing, not increasing, but decreasing HBV DNA, increasing ALT, and most importantly, increasing age, that's when the risk probably starts to increase. And so that's recognized in the guidelines, and defining old varies by where you live. So in Asia, you're old if you're over 30. You got to wait till age 40 to qualify for treatment in the AASLD guidelines. So you may consider treatment, particularly in older IT patients. We're sort of stuck with long-term nuke therapy. I wouldn't recommend using interferon in this group, and hopefully newer therapies will actually be the answer. Now, what do we do with patients who are not on the IT side but are in the gray zone? And this is the gray zone are these people that don't quite fit into those neat little boxes in the flowchart. And you can see that there's this very complicated algorithm here to define what is the gray zone. And I've tried to make this a little simpler. So you've got inactive patients. We all agree they've got normal ALT, lower undetectable HBV DNA. Then you've got some patients with high ALT but low HBV DNA. Of course, that could be something else. It could be fatty liver, Hep C, something else. They've got low ALT but high HBV DNA, so they're just not active, this middle group. And then you've got groups that are a slightly elevated ALT but doesn't quite meet that threshold for triggering treatment and a high DNA. And again, there's some useful data that have come out recently to look at this group. And again, this was a study from Korea that looked at this, and they took patients that didn't quite meet the definition for treatment, at least by the AASLD guidelines. You can see that they had an ALT that was elevated but less than twice normal, and they compared them to a group of patients who had active disease and met the treatment guidelines. And what you see is that the treated patients did better than the untreated patients. So these would be these untreated patients would be patients with minimal ALT elevation, didn't quite reach the threshold for the guideline recommended treatment indication, and you can see that their risk of cancer and of death or transplantation was higher. So what does this suggest? Well, it does suggest that probably the AASLD should lower the threshold for a treatment indication, and we should be thinking about treating anybody with an ALT elevation. So bottom line, the current guidelines are probably actually appropriate if you can read through them all. They're very complicated. There's lots of caveats to low ALT elevation. So they say, well, you know, if these patients that are in the gray zone, you can biopsy them. If they've got a persistently mild ALT elevation or they're over 40, you can treat them. If they have a family history of cancer, you can treat them. But these are real subtleties that are easily missed. And really, the reality is we're unlikely to have a big randomized trial to compare these two groups. There's a relatively low absolute risk. You'd need huge trials and very long follow-up. So it leaves some ambiguity, and we know that people are not too keen on biopsying people with chronic hepatitis B. So it might be simpler to just extend this to any ALT elevation with an elevated HBV DNA. You do want to make sure that the HBV DNA is at least above some threshold. In this case, 2,000, I think, is reasonable, to make sure that it's actually the Hep B that's driving the ALT. So it's not fatty liver or something else, but provided there's any ALT elevation and HBV DNA above 2,000, it seems reasonable to consider treatment in this setting. So this, of course, begs the question, should we actually treat everybody? And there is actually some push to treat everybody. And interestingly, the Chinese guidelines just came out recommending that everybody over the age of 30 that has a positive surface antigen and a detectable HBV DNA should be put on antiviral therapy. And that's important because China still is the largest reservoir of chronic hepatitis B globally. And this is particularly true in low and middle income countries where diagnostics are actually often more costly than the treatment itself, and follow-up may be difficult. So the rationale here is that with generic drugs, it's likely more cost-effective than our current guidelines. The drugs are safe and resistance is rarely a problem, and benefits that may be difficult to demonstrate in a clinical trial may be apparent at the population level. So you can see in Taiwan, where they instituted very early vaccination and early treatment, they've seen reductions in liver cancer incidence over time related to that. And there also may be a transmission benefit of treating more people and preventing transmission. So if you look at this from the provider perspective, so this is interestingly, patients have really been pushing for this, in part to reduce stigma, to have some autonomy over their disease. If you take this from the primary care provider perspective, the serology is complicated, guidelines are complicated, monitoring is a little complicated, stopping is very complicated, referral's pretty easy. But if you take this from the specialist perspective, they say Hep B is complicated and I'm an expert, so don't you dare we couldn't possibly think about putting people on very safe, very well tolerated treatment who might not absolutely need it. Well, does that really make sense? Let's think about the consequences of overtreatment. So our conservative approach currently is when in doubt, don't treat. If they don't quite meet the threshold for the guidelines, don't treat them. But our very wise chair made this good point at a recent conference on discussing expanding treatment guidelines, that maybe we should change what conservative means. Should we change this to when in doubt, treat? Because we've got very safe and effective treatment. So maybe in the areas where we're unsure, we should actually err on the side of treatment rather than not treating. And I think he may be quite wise in that. And if you think about Hep C as the example, we have about a 99% SVR rate. Treatment almost certainly could be shortened for most. Most people will never develop liver or non-liver related bad outcomes from their hepatitis C infection, yet we err on the side of treating everybody because it's safe and easy, and it will have benefit at the population level, even if there's uncertain benefit for the individual. And as Susanna pointed out, despite the fact that it's costly for the individual, it's very cost effective and likely cost saving in a short time at the healthcare level. So for Hep B, it's not quite as simple as that, but we're maybe making it harder than it needs to be. So last thing I'm going to talk about is once you start, can you ever stop? And this idea of using stopping therapy as a therapeutic strategy has gained some traction. And this is sort of this nice, complicated diagram, but it's helpful to think about it, where what happens when you stop long-term nukes, you see this predictable rise in HBV DNA in almost everybody. And then what happens is not so clear. Some people will then come right back down and go back into inactive disease and even potentially clear surface antigen. Some people will have a flare in ALT that will remain active or go back to normal, and some people will have high HBV DNA after you stop. So you can see that this is a bit of a mess. It's very hard to predict what's going to happen when you stop therapy. So this was a nice cohort study that was pulled together from a number of international sites to try to get a handle on this. What happens when you stop long-term nuke therapy? And so this was done primarily in Asian and European cohorts, and that's going to influence the data. You see over 1,500 patients, and about 88% of them were Asian, and you can see that they'd been taking nukes for about 3 years prior to this. And you can see that the surface antigen loss rate, so this is clearing surface antigen after stopping the nukes, was 14% at 4 years. So a little bit higher than what you'd expect without treatment or with continued treatment, but about half the patients needed to go back on therapy. And if you looked at who did better, interestingly, patients who self-identified as Caucasian or white had a much higher rate of surface antigen clearance than Asian patients. And also the surface antigen level at the time of stopping. Quantitative surface antigen, which unfortunately is not widely available in the US, but is available in most of the rest of the world, was also a strong predictor. And you can see that people that had a low surface antigen level, less than 100, had a 22.5 higher likelihood of clearing surface antigen. So this led to these guidelines that suggest that for Caucasian patients, and I suspect it's probably also true for Black patients in the US, because this is probably more about adult-acquired disease than vertically acquired disease, that stopping, you need a lower threshold of surface antigen, so below 1,000, they had about a 41% S loss rate, whereas for the Asian population, you needed to get below 100, and even then, it wasn't quite as likely to lead to surface antigen loss, so leading to these two different thresholds for clearance. Now, one of the questions that's come up about this is, would a flare actually help? So does an ALT flare actually lead to surface antigen loss? And so this study from the Hepatitis B Research Network looked at taking patients off therapy and then letting them flare. So these patients were all on tenofovir for 4 years, and then looked to see if they flared, did that actually lead to surface antigen loss? And interestingly, what they saw is that the patients without a grade 3 flare, so a 5 times the upper limit of normal, actually had a higher surface antigen loss rate than these patients who did flare. So interestingly, flares didn't seem to be helpful, but they actually could be predicted. So patients that, if you looked at their baseline, older age, and higher HBV DNA before they went on treatment, were associated with flares. Unfortunately, nothing at the end of treatment. So when you stopped treatment, you couldn't predict who was going to flare. But at the visit prior to the flare, if their HBV DNA was above 4 logs, they were extremely likely to subsequently flare, and the flares did not seem to be helpful, so they could be potentially prevented. So the conclusions on this are surface antigen loss is very infrequent after withdrawal, particularly in Asians. ALT flares are not required for S loss, and this sort of questions this concept of a therapeutic flare. If you have a high HBV DNA, the DNA goes above 4 logs, trigger restarting therapy at that point, because some patients will have severe flares, and there actually have been deaths. So don't wait for the flare is not going to help. So if you're considering nuke stopping, only in people without cirrhosis, only in people who are E antigen negative and anti-E positive. These are people that must be willing and able to follow up reliably. In Asians, use the threshold of less than 100 IU per ml, and in Caucasians, less than 1,000. Follow patients closely after you stop, and if their HBV DNA goes above this threshold of about 4 logs, restart. They're not going to benefit from a flare, and it's very likely to happen. And hopefully there will be new therapy on the horizon. This is an intentionally complicated picture of what's coming, but you can see that across the viral life cycle, there are a whole bunch of different approaches looking at antiviral strategies and immune stimulatory strategies to address hepatitis B. And hopefully within the next 5 years, we're going to have new approved therapy for hepatitis B. So to conclude, currently available therapy is highly effective, but does require long-term use. There's general agreement across guidelines for most areas. There's some ambiguity in immune-tolerant patients, probably merit treatment, particularly for older individuals, but our current therapies are not ideal. Minimally active disease is also somewhat controversial. It would be nice to see some harmonization between the guidelines, and hopefully, I think, to see the AASLD guidelines move to a bit more lean towards treatment. And safe and generic drugs raise the prospect of actually treating everybody. If you're going to stop therapy, you've got to be careful about who you do this in, and you've got to be really careful that you follow patients closely, and remember that ALT flares are probably not helpful, and ideally use quantitative surface antigen if you have access to it to predict. Hopefully new therapies are on their way, and we will be talking about them in the OPMAN conferences to come. And with that, I'll thank you and be happy to take any questions.
Well, great. Well, thank you for that attempt to simplify a very complicated disease state, Jordan. I realize in the juxtaposition of Hep C and B, how different the approach to these viruses really is, and they're very different viruses, so there's some rationale for that. So we do have a lot of questions, and those of you at home, please keep them coming. We've got about a good 15 minutes or so for questions, so we've got some time to dig in. And there's some really good ones. Let me start with the microphone, actually, here in the room.
Thank you, Mark. Thank you, Dr. Nagy. You're such a motivator. I really appreciate seeing you speak. And Dr. Lake, thank you. I have more of a comment than a question. If you don't think you can make a difference as an individual, you can. As a simple family doctor without an academic association, Florida Medicaid has allowed me to speak to them 4 times over 4 years. They've removed the provider requirement. They removed the sobriety requirement. They agreed that we should treat people who are still actively using. And in December, they came that close to removing prior authorization, but they're now doing auto PA, and we're getting approvals in 4 hours. So
Nice.
those of you in Florida, please get back and treat these patients. Thanks.
That's great. That's what I'm talking about.
Yeah, no question that advocacy helps, and that there are a couple questions about prior authorizations, so I'll touch on that, but they are a major barrier to a test and treat model. If you have to test, ask the insurance company, wait multiple weeks, it ruins the model. You can't do it, and that's where I think the Netflix model might be helpful. You can just tap into treatment, we hope. So we'll take another question here at the microphone.
Thank you both for excellent talks. Yesterday we heard about STIs, and today, especially for Dr. Nagy, hepatitis C. We've been taught in the past to test for patients in the cohort from 1945 to 1965 or 60. And now we have a lot of, in fact, I treat many gay men, gay people. Should we be testing all of these on a regular basis?
Absolutely, that's a great question. So again, universal screening is really meant to get to people who are at risk actively of acute infection or new infection, but largely chronic infection. So certainly if you are caring for populations that are at risk, that are developing other sexually transmitted infections, then yes, my recommendation is to test those patients as well for hepatitis C. We've seen this in data from PrEP clinics that in high-risk people who are being treated for PrEP, so at risk of HIV and other infections, HCV is common, increasingly common. So I think that, at a bare minimum, I would argue that in someone who's high risk, if you indeed are diagnosing STIs, HCV should be tested for. the question is, what do you use? Do you know what their Hep C antibody status is already? Should you be using an RNA? Those are things to think about. But I think the current guidelines recommend kind of 6 months in the higher risk populations, and I would say that's at a minimum. I do that as well as if there's a diagnosis of an STI, I make sure that HCV is also tested. So that's been implemented in my care.
Yeah, I would just add that it's just a really important point about the guidelines recommend one-time universal screening in all adults. The important thing is in people with ongoing or new risk factors is to continue doing serial testing. So it's not the one-time testing applies for people with no identifiable risk factors.
So a number of questions online. Let me maybe take a couple of them. There was questions about the management of acute hepatitis C. And the question in particular asked about where do we stand with waiting for spontaneous clearance? We do know that some people, perhaps in part genetically related, will clear spontaneous hepatitis C. So there was in the past guidelines recommend waiting. The question was, do we wait or treat, and how does that impact into the this idea of the national elimination plan? So we'll pose that question first.
I mean, I'm happy to start. I mean, bottom line is the ASOD-IDSA guidelines quite a while ago now made the recommendation of treating patients for acute hepatitis C at the time of diagnosis. So the concept of kind of waiting and monitoring, we recognize, really was significantly delaying. In particular populations like people living with HIV, we know that clearance rate is very low. But honestly, in people who do not have HIV, the clearance rate is still very low. And so the guidelines really took that step to say waiting is not something that they recommended. I think every individual provider can do things differently. Sometimes when I have a patient referred to me, their viral load at testing is 10,000 or 50,000, and when I see them, I may test them one more time to make sure they don't clear. But the concept of monitoring someone out for at least 6 months like we used to recommend is definitely not something that is recommended by the guidelines, nor part of my current clinical practice.
I guess I would just highlight that someone with acute hepatitis C, by definition, has recently had a high-risk exposure. That's how they got acute hepatitis C. So if you think about that, and you think about the fact that acute hepatitis C is much more infectious than chronic hepatitis C. So the virus in someone who's had the infection for years is actually coated with antibodies and is less able to infect people than a virus that's just recently entered a person's body. So the acute hepatitis B transmission, so first of all, you've got a population of people who have recently engaged and are likely to engage in high-risk activities again, and you've got a more infectious virus, often with very high viral loads. So this is a group where treatment, and you also may have a group that's less stable because of the high-risk activities, particularly if it's injection drug use, so you may not see them again. So part of the reason for thinking about going to early treatment and not waiting for clearance is to really make sure you keep people engaged, but also this prevention benefit that you treat people. And even though you might treat some people who were going to clear anyway, in the time before they cleared, they may well have transmitted it. So if you can treat them and get them on therapy in that time, and it's actually been shown to be cost effective. So sometimes people think, well, why are we spending money if they're going to clear on their own? The reality is it's actually cost effective to treat people with acute hep C.
Yep.
So somewhat related to that is a question about a needle stick exposure. So there was one point in time at the Johns Hopkins Hospital where hep C needle stick exposures were really quite common. We're seeing less of that because fewer people are viremic now. We've cured people. But let's say you get a call from a healthcare worker who's had a needle stick, person's known to be hep C viremic. We'll start, Susanna, what do you tell that person? They're a little bit anxious, by the way.
They're always a bit anxious in my experience, which makes sense, frankly. And I've been one of those, so we know how that feels. I still try to reassure people that our hospital has not had an HCV infection in a healthcare provider ever. And a lot of that has to do actually with the multiple methods that we've put in place in terms of double gloving, et cetera, right? So I try to reassure them that historically they are unlikely to be the first case, and to reassure them that we have changed our recommendations in terms of monitoring to HCV RNA. That is actually in guidance with the MMWR that was released by the CDC probably, 2 years ago now, to really change the way we monitor. I feel like that reassured people. To say that if we see early detection of RNA, then we will rapidly treat you to the point. And so I try to reassure people that we're going to do very early monitoring for an RNA and get you on treatment as soon as possible, but that history says you're not going to convert. It's a very low risk situation.
And I think just to really distinguish it from the scenario we were just talking about with acute hepatitis C, first of all, as Susanna said, the risk is really low. Estimates suggest it's about a 1 in 200 risk of becoming viremic if you had an open bore needle go into you with blood in it. So the risk is quite
and
low.
a non-gloved hand,
And
all those
non-gloved
other
hand,
things.
right? So the risk is low. And this is also usually a healthcare provider who is not the person who's necessarily engaging in high-risk activities and going to get lost to follow-up. So really just reassuring the person they're not likely to get infected, and if they're unlucky enough to become infected, we've got highly effective therapy and you're going to cure them very quickly, is usually reassuring, and I totally agree with doing HCV RNA instead of antibody testing.
So great. I want to move to, there's probably two topics I make sure we talk about. One of them, and maybe we'll dig into this one first, is how to manage people who are hepatitis B core antibody positive. We'll talk about this a bit later in the cases, but there is a recommendation now from the CDC to test every American for 3 tests: anti-S, anti-core, and S antigen. So we're going to see more people who test positive for core antibody, suggestive of past exposure, but maybe negative for S, or how do we manage those people? And the question is actually 2 questions online. Do we vaccinate those people? And a corollary to that, with or without HIV, do we differ in how we vaccinate? So complicated questions about serology, but we're going to get a lot more of these, I think, coming up.
Yeah, so I guess I can.
We'll start with Jordan.
But on hepatitis B, so obviously this is going to be a common scenario that we're going to see a lot of people who are core antibody positive. For the most part, so people used to worry about this being a false positive. The newer assays are pretty good, so we rarely see false positives in this setting. You can certainly, in someone with any risk factors for exposure, either their country of origin or any activities they've engaged in the past, you can assume it's a true positive. Most important thing to make sure is that they're surface antigen negative, and if they're surface antigen negative, you can reassure them, but there are a couple things you should do. One is make sure that you screen their family members and contacts. Don't forget that, because if they've had hepatitis B, if it's in the family, they may have been surface antigen positive in the past and passed it on to a household contact, so don't forget that part. And then it's important to remind them that if they're getting immunosuppressive therapy, and it's potent immunosuppressive therapy, so here we're talking about things like rituximab, so B-cell depleting drugs, or a stem cell transplant, then they have a risk of hepatitis B reactivation. Fortunately, the risk is quite low with standard solid tumor chemotherapy and other less immunosuppressive regimens. So and the only other thing I would say is you should do a quick screen to make sure you don't think they have cirrhosis, because some people can clear surface antigen even after they have cirrhosis, and if they do have cirrhosis, they need long-term follow-up for their liver disease. I'll let you take the HIV question. Does it change?
So the question specifically was that the guidelines, the OI guidelines, actually suggest vaccination for someone who's isolated core positive.
Yeah, I mean, I would say that what I've done in my practice for those patients, and again, I think it's actually really nice. When I first started training, there was always this debate about being a false positive, and I think there's been really nice data out of some of the longer-term cohorts to say that if you really look back in serologies in these patients, they had a positive surface antigen, they had a positive surface antibody, or they never developed an antibody, but they cleared their antigen, probably just a lot of antigen, soaking up that antibody, and they have cleared. I mean, we can talk about occult Hep B if you want, but bottom line is that I tend to booster these patients to see if I can get an antibody that is detectable. If they don't, then I tend to redo a vaccine series. And for the majority of patients that I take care of, both and with HIV, they tend to convert. So that has been my practice as well.
Would you do that in people who don't have? I agree, in people who have HIV. What about in mono in people without HIV?
Yeah, it's interesting, right? So those patients, it depends on where you find them,
Yeah.
right? So, the way that we usually hear about those patients is that they're about to start chemotherapy.
Right.
And in some cases, they're going on Hep B therapies anyway, and it's happening soon. I think it's a great conversation. Generally, I have not really had the opportunity to vaccinate them because they're getting put on therapies, but I don't know if it's worth a try or not. Do you guys do that?
Yeah, we don't generally do it, so that's why I mean I think in the people living with HIV it makes sense to do it because they do have some risk of reactivation even just because of the HIV if it's not well controlled. But in people without HIV, I don't generally vaccinate them, and I don't know, Mark, what do you do?
You say you do vaccinate?
I do not vaccinate.
We
people
tend
who are-
not to
Tend to
vaccinate.
mono,
We do tend not to vaccinate. I actually tend to be fairly, I'll use the word aggressive with the use of actually typically entecavir prophylaxis in
Yep.
patients as opposed to vaccine. But I do agree the guidelines are a bit
Ambiguous.
less than definitive in this. But let me go to the microphone and a couple questions on the microphone.
Can you hear me? Follow up on vaccinating people. Do you have any recommendations for which vaccine to use?
I have a case on this, so.
Oh, very good.
But go ahead. But short answers.
Short answer, I'm gonna look away from Ken Sherman's gaze. In my clinical practice, we use the Heplisav vaccine.
And just to highlight, the Heplisav is the one with the TLR9 agonist, so it's a bit more immunogenic, 2 doses.
Regardless of HIV status.
Let me go to the back to my right of the microphone.
So, in the co-infected HIV patients who are core antibody Hep B positive, they're surface antibody negative, they never respond to vaccines. We mix vaccines sometimes if they've had previous, we go to the Heplisav to see if we can get an immune response, but say they never do. Now you're thinking about switching them to a 2-drug regime, which does not cover hepatitis B. Do you check viral loads on I check viral loads on these people and monitor them with their ALT because I'm afraid of response, but nowhere is that written as standard that I've ever found.
Yeah, I would say, my take on this for those patients, I have patients that I have taken care of with HIV Hep B who clear their surface antigen. And those are people I probably tend to be a little bit more conservative with in terms of monitoring. But I will say we're seeing data now, right, coming out presented at CROI of patients who are isolated core antibody with HIV Hep B who are stepped down to a nuke sparing regimen and are having flares. And I think this is not surprising. I think the question is, what are the real numbers? I'm not sure we know for certain what the prevalence of that is, but I think the recognition that this is that this is something that can happen is important. It's probably worth having a conversation about how you implement that in your clinical practice, right? Where are you in the clinical practice? Can you do monitoring for liver transaminases and DNA? I think the reality is knowledge that this can happen is probably more important than anything. Most of these patients are in care and are having labs drawn, so it's relatively straightforward to do monitoring. My take right now is probably that if I were, as we're switching more patients to long-acting, as I probably will for the time being until I understand the overall risk. But I think this is evolving, right, as we're making these step downs.
So I'll remind you that we have Debica is going to talk about management of HIV Hep B a bit later today, so we'll get into that. I think the lesson is don't turn your back on hepatitis B. Don't trust it. It's a sneaky virus that sets up a latent reservoir. So never turn your back on it. You can move it down the problem list, but don't take it off the problem list. We'll do one more question in person, then I've got another question for you guys. So we'll do in the microphone.
For Dr. Feld also, what to do about people who fail 1 or 2 rounds of hepatitis B vaccinations?
Okay. Yeah, it's a good question. So in people so I'm going to take the scenario of people without HIV who fail vaccination. So the first thing is that if they've failed once, it's important to think about the risk. So why are they being vaccinated? It's recommended to vaccinate everybody, but in people who are going to be at ongoing risk, so if they're healthcare workers, sex workers, people using injection drugs, these are people where you really want to make sure that they respond to the vaccine. And of course, if they have an intimate contact or family member. So those are people where you really want to go to some length to get them to respond, giving them, so you can either switch to Heplisav, which is a slightly more immunogenic vaccine for a second course. You can give a second course at double dose of the original hepatitis B vaccination. If they don't respond to 2 courses of vaccination, they're very unlikely to respond with subsequent courses. This is actually HLA associated, and they're very unlikely to respond. It doesn't absolutely mean they're not protected. They do probably still have T-cell responses. So just like with COVID, antibodies don't tell the whole story. But we worry about those people because you're not likely to get them to respond. So at least for me, we don't have the Heplisav vaccine in Canada. So we do 2 courses, and if they don't respond, we just tell them about that. And then depending on their risk profile, whether or not that really is how important it is. I don't know if you would add anything to that.
No, I agree.
Well, let me try to squeeze in one quick question. There were some questions about liver cancer, HCC monitoring. So Susanna, after cure, how are you managing for a patient with cirrhosis, they're cured, some of those patients are 7, 8 years out. Are you still continuing to do HCC screening with ultrasound every 6 months?
I am. Yeah.
And the guidelines have not shifted on that point.
The guidelines have not shifted on that point. I think we have a lot of studies out there suggesting that you can use non-invasive markers and including elastography post-SVR over time. I just think I need more evidence before I'm willing to step down in HCC screening. I will tell you that I also have the experience of patients who are 8 years out post-SVR who develop an HCC, and it's those individual cases that probably also further drive me to continue HCC screening for now.
But I think
Jordan,
the other thing,
I was going to ask you about B. Are you going to?
well, I was just going to say in C, the other driver, it's important, yes, the risk goes down as you're longer out from cure, but the thing that's also happening over time is you're getting older, and age is such a strong risk factor for HCC, especially in people with cirrhosis, that if they have cirrhosis before starting treatment, my guidance is don't stop ever, at least for now.
And people don't get younger, right? They just
People
keep
don't
getting
get
older,
younger.
right? Yeah.
We've tried, but no.
So hepatitis B is a bit more complicated. What is your approach to the liver cancer screening in your B patients? Is it age? Is it I'll let you answer the question.
So as usual, the guidelines are more complicated than with C. so it's anybody with cirrhosis, and it's ever cirrhosis. So remember, if you see someone who had a diagnosis of cirrhosis 15 years ago and you see them in your practice and they've got a normal FibroScan, that doesn't mean cirrhosis is gone. They're still at risk for cancer. People with a family history of HCC, and then for everybody else, it's age and sex and to some degree ethnicity driven. So for men, the risk is higher than women. So we start screening at age 40 for people with chronic Hep B, for women at age 50. And there is a bit of a question about how to mix in ethnicity into this. They've changed the AASLD guidelines around Blacks. There used to be a recommendation to start at age 20 because it was recognized that people born in Africa have a much higher risk of liver cancer, possibly to do with aflatoxin exposure. They don't recommend that in the current AASLD guidelines, but I think at least for my practice is still that I have a lower threshold to screen people who are of African heritage, particularly if they were born in Africa, even if they've immigrated.
Well, we're going to stop there. I want to thank our 2 speakers for their excellent presentations and fabulous discussion. We did open the can of worms known as hepatitis B serology, and we'll have time to talk about that a bit more. I recognize these are complicated topics. And as I mentioned earlier, we shifted a little bit because of the air travel constraints that we faced. And I'm really pleased to invite Ken Sherman to the podium. Ken has been a longtime faculty member at the OPMAN, and he has talked on a variety of topics. This year, we've charged him with reintroducing us to a pathogen, hepatitis D, which is reemerging with new treatment options. So Ken, I'll turn it over to you.
Thank you, Mark, and I'd like to thank you and Mike for, again, inviting me to come here and to talk about this topic, because it's not something we talk about a lot, and it's reemerging because we're starting to think about it as there are new treatments, and we're just beginning to get a handle on the epidemiology and the prevalence of this disease, which is probably higher than we have thought about over the years. These are my disclosures. So what is Hep D? Well, it's a virus discovered by Mario Rossetto in Italy in 1977, and it's rather unique. It's the sole member of what's called the Delta virus family, and it's the smallest known mammalian virus. It's only got about 1,600 bases. It's incredibly efficient, and in part because it works with hepatitis B and therefore is called a satellite virus. It's globally distributed but unevenly. So it's not like you could sample, and we'll look at that, any one population and know how much Hep D there is. And it's important because it's associated with more severe acute disease, more rapid fibrotic progression, and even higher rates of HCC when it's present. This is a slide comparing it with Hep B. It's a different genus and family than hepatitis B. Hep B's genome is a partial double-stranded DNA. This is a single-stranded negative strand RNA. But the cell receptors are the same, and that's one of the clever uses of this virus for a way to fit an evolutionary niche of, oh, look, Hep B makes too much surface antigen, which it's using as a way to suppress the immune system through immune exhaustion pathways. And Hep D says, you know what, I can use that. I don't need to make a surface antigen. I could just coat myself and then use the same receptor. And we'll look at that a little more closely in a moment. Hep B is clearly vaccine preventable, but Hep D is too. If you prevent Hep B, you're not going to get Hep D. They both cause acute and chronic disease, and they both are associated with development of liver cancer. But when Hep D is present in the setting of Hep B, that risk of liver cancer is significantly increased. So this is the sodium taurocholate cotransporting polypeptide, which is a transmembrane protein that's highly expressed in human hepatocytes. It's the only place it's found is on the hepatocyte. It mediates transport of bile acids, and it is the co-receptor that's used as the key receptor for HBV and HDV entry into the hepatocyte. If we look at the HDV replication scheme, basically Hep D enters the cell through that receptor, uncoats, loses that surface antigen, and uncoats further its own antigen, is transported by an active mechanism into the nucleus, where the antigenome gets converted to a positive strand and then becomes the template for additional negative strands. There is the use of a human polymerase II as part of the replication process. So again, this virus makes use of its host to do its job for its replication. It then has to rejoin as it comes back together again with new pieces of nucleic acid with that surface antigen from hepatitis B, gets transported first in the Golgi and endoplasmic reticulum, and then is excreted from the cell to start the infectious cycle again. We'll see a picture like this again, but talk about the intervention sites. Hep D does exist in a variety of genotypes. Globally, the most prevalent is genotype 1. In some areas, one genotype is prevalent within a more broad area of genotype 1 being present as well. And there's a couple of really interesting genotypes in here. Among them, genotype 3 is the cause of La Brea fever, which is a nearly universally fatal form of hepatitis D that exists in the Amazon basin. And so if you have Hep B, we actually recommend our patients not go on their next National Geographic trip to the Amazon basin. The epidemiology broadly is shown here. Clearly parts of the world, sub-Saharan Africa, Southeast Asia, much of the Soviet Union, parts of South America, are very high prevalence of Hep D in the setting of Hep B. Now, those are places where Hep B is also quite common. Again, the problem being that it's not evenly distributed within all of those areas. And you see this in the little circle box talking about prevalence, that we don't know the prevalence of this virus. The WHO did a survey in 95 countries and came up with an estimate of about 12 million cases worldwide. But another study based upon a meta-analysis of published data from 83 countries ended up with an estimate of up to 60 million. Broadly speaking, people have suggested that about 13% of people globally with hepatitis B have hepatitis D as well. But again, tremendous variation even within an area that you think you might know the prevalence for, and we don't know the real number. HDV in the US among HIV-infected persons, there was a recent study, cross-sectional study looking at 8 US centers. Samples were tested for Hep D antibody, which is the initial testing method, and it was present in about 4% of persons living with HIV and Hep B. When they followed up with testing for HDV RNA, it was only present in a small subset of that and in varying titers, most of them fairly high, and they were all genotype 1. So what are the variables affecting prevalence? Well, starting with the guidelines, we heard a lot about guidelines in the previous 2 talks. The AASLD says that we should be doing risk-based testing for hepatitis D. That differs from the European guidelines and the Asian Pacific guidelines, which say basically everyone should be tested. The availability of testing, the ability to order one of these tests varies widely around the world. And if you're going to start with an antibody test, not only may you not be able to get the antibody, but most places find that they're not able to order HDV RNA. Most clinical laboratories do not run this. There's only a couple of the large laboratories like LabCorp and Quest in the US that run these assays. And finally, there's the awareness issue. Most people are just not aware of D, and so the test is never ordered. In terms of thinking about those prevalence estimates, we need to be aware of the different sampling methods that are used in different regions. There's clearly a bias towards studies being done in academic medical centers that have a concentration of patients with cirrhosis and hepatocellular carcinoma, which tends to inflate those estimates. And there's large missed populations on the other side, including those with persons who use drugs, injection drugs, and those with HIV, where this testing is uncommon. We looked at this and published this study a few years ago in our center and found that only the hepatologists were ordering hepatitis D, and the HIV care providers virtually never ordered a hepatitis D test. And when we actually did the testing ourselves in a large cohort, we found that the HIV infected were accounted for about 50% of our case burden. The risk factors are shown here in decreasing significance, and you could see from the list that that patients with HIV are likely to be relatively high risk, both on a risk factor basis and also those that are actually known to be directly HIV positive. Chronicity of Hep D is directly tied to when you get it relative to hepatitis B. So if you already have chronic Hep B and are then exposed to hepatitis D, the D is also going to become a chronic disease. I mean, better than 90%, probably 95% plus. In the setting of co-infection, the risk of chronicity is again tied to the risk of chronicity of B, and that varies greatly based upon a series of other risk factors, including the age of infection and whether you are immunosuppressed at that time. A healthy adult male getting Hep B has less than a 1% chance of developing chronic B, and therefore a low chance of getting D. But if you're HIV positive with low CD4, that risk may go to 10, 15%. So we have significant differences based upon a variety of factors. In terms of progression to cirrhosis, it's very clear that the combination of these two viruses leads to much more rapid progression of fibrosis to cirrhosis. And similarly, that combination leads to an increased incidence of liver events, decompensating events, hepatic encephalopathy, or development of ascites or complication with liver cancer. And if we look at the setting of HIV, we see that, I got to clear this one and put this. This is the group of HBV, HIV, HDV that is at a significantly higher risk of death and development of liver cancer over time. And that's in comparison to patients who have HCV with HIV or HBV with HIV. So what about treatment? Well, I have discussed this virus in several settings for ID audiences, and I often hear that my patient is on a nuke, therefore I've already treating this because I'm treating the Hep B and the Hep B is well suppressed. It's important to remember that the location, the mechanism of action of the nukes does not in most patients lead to the clearance of the surface antigen. We heard that in Jordan's talk a little while ago. And as long as that surface antigen is being produced, you can continue to replicate Hep D. So nukes are not the treatment for hepatitis D. So what are the therapeutic options? Well, we have to return to the life cycle and see the different targets. And those targets can be at the level of entry. They could be at the level of replication with agents like interferon or perhaps silent or small interfering RNAs. It could be at the level of assembly or trying to deal with the enzyme that's involved with linking the surface antigen to the Hep D. And all of those represent potential therapeutic targets that are being explored. So we'll now look at some of that data. The classic treatment data of Hep D was with pegylated interferon. This is the standard therapy. And you could see in this figure that the use of adefovir alone led to zero clearance, but if you used peg interferon with adefovir or peg interferon with placebo, you actually got the highest rates of HDV RNA clearance. We already heard that there's not much enthusiasm for use of interferon. We used to use interferon a lot in Hep C, and it's sort of fallen by the wayside, and particularly in the United States. In European guidelines, there's still a fair amount of use of interferon in many countries for Hep B, and so that jump to thinking about using it for Hep D is not that great, but here we just don't see it done. So another new treatment to consider is bulevirtide. Bulevirtide was originally known as Mercludex B. It's an injectable. You start with a lyophilized vial and have to reconstitute it. And there's been a couple of early studies when it was called Mercludex. The name has changed now to bulevirtide. One study with a nuke, one study with interferon, and you could see that that if we focus on levels of HDV RNA, that both were suppressive, the interferon combination appeared to work better. This is an agent that's going to be blocking that the sodium taurocholate co-transporting polypeptide receptor. In a phase 2/3 trial, looking at pooled data from those trials, patients with chronic Hep D, with or without cirrhosis, but all compensated, with an ALT between 1 and 10 times the upper limit of normal and HDV RNA present, patients received either 2 milligrams or 10 milligrams, and there were untreated controls in this study. The blue represents the combination response, which meant viral response and an ALT response. And you could see that the best results were achieved in the highest dose, the 10 milligrams associated with ALT, with the combined response not as good. So you're sort of choosing what do you want to do. The current recommended dosage in Europe is actually the 2 milligram dose, and that's what commercialization is going forward with at this time. And there was a study in HDV in patients with cirrhosis, 20 patients already on nukes, and they all were Child-Pugh A patients. ALT normalized in 85%. Interestingly, the patient's Child-Pugh scores went from 6 to 5 in 80%, and 2 of 9 patients with varices had disappearance of the varices, suggesting that there were important clinical outcomes to the use of this therapy, and this treatment was very well tolerated. There's very little data in the setting of HIV infection. This is the only data that exists. It was presented just a few weeks ago at CROI. 21 patients. It was a pooled European early access cohort. Patients received either bulevirtide 2 milligrams sub-Q a day or bulevirtide with PEG interferon. Why the difference? Because investigators were actually allowed to use whichever they chose to use under this early access program. The endpoint was a composite endpoint, 2 log reduction in HDV RNA and ALT less than 40. And you could see that that good results focus on the red, which is the 12-month result. In the bulevirtide alone, approach 60%. Interestingly, the 3-month results for the combination therapy were higher than that, but because of dropout due to the intolerance of the PEG interferon, they actually didn't do as well overall on an intention to treat analysis. So where do we stand with this drug? Well, monotherapy with bulevirtide appears to be safe and effective. The combination with PEG interferon induces cure, it appears, in a subset of patients. The agent is conditionally approved by the EU in 2020, designated breakthrough status by the FDA in 2020, but in November 22, the FDA issued what's called a complete response letter and said that because of issues of manufacturing and delivery, they would not approve at that time. We do expect to see approval in the US at some point in the not too distant future. Let's look at another agent, lonafarnib. Lonafarnib is a small molecule that's a prenylation inhibitor. It binds and inhibits farnesyltransferase, and it prevents the association of the large delta hepatitis antigen with hepatitis B surface antigen. It was well characterized in an oncology program years ago. It did have dose-limiting toxicity in terms of GI side effects, and it's FDA approved for treatment of progeria. It has orphan designation in the US and Europe and is fast-tracked in the US. And prenylation is a host target, which is a potential barrier to resistance. In the lower one study, we see that the use of this agent with PEG interferon or with ritonavir as a boosting agent led to very rapid decline in HDV RNA, better than the use of PEG interferon, which again has been the standard therapy. I'm going to skip the phase 2 trial, jump to the phase 3. This is the D-liver trial. Lonafarnib with ritonavir lonafarnib with ritonavir and PEG interferon alone, or placebo. The primary endpoint was a greater than 2 log decline in HDV RNA and normalization of ALT. But importantly, and we'll look at this data in this study, they did liver biopsies and looked at fibrosis. So here are the results, the virologic decline on the left, the ALT normalization on the right, and we could see that in terms of viral decline, actually the two best performing were the combinations that contained PEG interferon. In the biochemical response, the winner was the lonafarnib with ritonavir. Clearly, in the setting of HIV, we're going to worry more about management because of drug-drug interactions with ritonavir as part of a regimen. But this is the histologic results, and I think this is very important. The histologic endpoint was a greater than or equal to 2-point change in the histologic activity index with no worsening in the Ishak fibrosis score. And the combination therapy had a 53% response rate in their paired liver biopsies compared to baseline. So the fact that we can actually see improvement in liver biopsies is quite significant, and we don't have that type of data with other agents at this point. Well, I told you already that PEG interferon alpha has been the standard therapy for Hep D for a number of years, at least in Europe. There's another type of interferon, lambda interferon. Lambda interferon's a little different. The receptors are more localized to the liver, and with that, we get less of the interferon side effects, so less neutropenia, flu-like symptoms, the musculoskeletal symptoms that limit the use of interferon. In a phase 2 trial, we see that lambda interferon at a dose of 180 micrograms had a significant effect in HDV RNA decline, suggesting that with less side effects, this might be a more viable agent and more accepted agent for use of in this disease process. And that agent has now been studied in combination with lonafarnib, ritonavir, with PEG interferon lambda, and this is a small 2A open label prospective trial, only 24 weeks, but there were complete responses in terms of clearance in a high proportion of patients. So looking promising. There are other agents coming. This is REP-2139, which is a nucleic acid polymer, phase 2 trial. Only 12 participants in the study, HBV, HDV without cirrhosis. It was injected once weekly for 15 weeks, followed by a complicated regimen with PEG interferon alpha combination and then PEG interferon alone. The top line results, 9 patients were HDV negative at the end of therapy. 7 were negative 1 year post-therapy, implying a sustained response was indeed present, and ALT normalization occurred in 9 of 12. There are non-human studies with agents using an siRNA agent. This is ARB-1740 in humanized mice, just showing one key result, significant drop with this agent in HDV RNA, and hoping that these agents go forward and probably become part of combination therapies in the future. So in conclusion, HDV is underdiagnosed. All patients who are HBsAg positive should be tested for HDV by antibody testing and confirmed with HDV RNA testing. New drugs are coming soon. Again, I think we will see licensed products in the US within the next year, and therefore we need to start identifying the patients that might benefit from those products. Thank you.
Well, great. Well, thank you, Ken, for that reintroduction to hepatitis D, which is, we're going to hear a lot more about that pathogen in the coming months to years, so it's important to get reoriented to it. Well, as I mentioned, we've recalibrated our agenda today, and I'm really thrilled to invite Dr. Glenn Treisman to the stage. He's going to talk about healthcare provider burnout. Now, Glenn is from Johns Hopkins, and I'll tell you, when I talk to people and introduce myself as someone from Hopkins, they often say to me, "You are so lucky to work with Dr. Glenn Treisman." And my response is always yes, yes, I am. I get to work with Glenn as I have for the last several decades, and we get to have his presence here at OPMAN every year for the last several decades as well. So with that, I'll invite Dr. Treisman to the stage. Glenn, it's all yours.
Thank you so much, and thank you for inviting me back to OPMAN. I really appreciate it. This is my favorite meeting of the year. Few of you know this, but part of the reason I ended up in the HIV clinic in the first place is because we were having an epidemic of burnout back 35 years ago when the HIV viral was just getting underway in terms of becoming a national problem, and people were burning out. How many of you know somebody, raise your hands, who is burned out or quit or retired early? Look at most of the audience. So we are seeing an epidemic of burnout right now in clinicians. And I wanted to talk to you about that because it's an incredibly important thing that nobody seems to be talking about. People are talking about COVID, they're talking about HIV and hepatitis C still, they're talking about lots of other medical problems, they're talking about long COVID, but they're not talking about the burnout epidemic. Without the clinicians, we can't treat anything. We need you. So what are we doing about it? I'm going to try to talk about what I think we should be doing about it. So I'm going to describe the challenges that you face with COVID-19 in light of other epidemics, mostly the HIV epidemic, and define the core elements of the patient-clinician relationship and discuss the anti-burnout effects of success. Conflicts of interest, these are my conflicts of interest. I think that you're supposed to put the best interest of the patient first and that we're striving for clinical excellence. However, other people think that we should decrease our length of stay, have problem-focused visits. There are no studies showing problem-focused visits are better than non-problem-focused visits. Never been a study of that. And in medical school, they taught us problem-focused visits when I was going to medical school 30 years ago, 30x years ago, without any data. This is the era of evidence-based medicine. We changed our entire practice to problem-focused visits based on what? Economics, no data. Cost-saving efforts regarding tests and medication. So my department used to circulate a little thing each month about everybody's pharmacy cost, laboratory cost, and radiology cost. I was always number one. I am number one. And so one year for Grand Rounds, I showed all these things. And I said, see how great I am as a doctor? And they stopped sending them out. Insurance reviewers, the bane of my existence, and probably the bane of some of your existence. Stewardship of resources. We're not doctors anymore. We're stewards of resources. Prior authorizations, which as far as I can tell, are just there to irritate me. For some of you, prior authorizations will actually prevent you from getting the patient what they want. It turns out you're much more aggravating to those companies if you just fight through it, but it can be really aggravating. Maximize revenues, evidence-based medicine in the form of saying, if there's no evidence, you shouldn't do anything, which is, for a lot of my patients, fatal. And then patient satisfaction, which I think is another economic pressure on you to do what other people want you to do rather than what you're supposed to do. Another conflict of interest is the Johns Hopkins bequest, which says, this is straight out of the bequest, which they hate when I quote this. The poor of this city and state of all races who are stricken down by any casualty shall be received into the hospital without charge. Surgeons and physicians, the highest character and the greatest skills. And of course, nonprofit status. However, every year I get a little P&L statement. They don't call it that anymore. They changed the name of it because it's a nonprofit. And I pointed out many times in lectures that if there's a P&L statement, that means profit. And they're nonprofit, so we should just have an L statement, which I'm good at L. The idea that healthcare is a business. Healthcare is a service. It is not a business. The police department is a service, not a business. We don't cut homicide and increasing parking because it's better business. The service is designed to help sick people, not to make money. And this idea that we are a business. However, we want you to, when you die, leave us your money, and we don't want to have to pay taxes, and we don't want to do any of the other business stuff that people are required to do, but we want to be a business when it comes to paying the CEO is a big problem for us in medicine. The emphasis on profits and request for a business plan for any new activity despite need. So I have clinics I want to start, and they say, what's your business plan? I say, I don't know how to make a business plan. That's why we have you guys. I know how to help sick people. That's what I'm supposed to do. This is very popular. Burnout is not a new problem. These are references to the HIV burnout problem from many, many years ago. And HIV burnout was a big problem. Most of you know about my own country by Dr. Verghese, who burned out. And he said, by taking up the case of AIDS, I had become tainted and tarnished. All I had to offer Luther was the ritual of the examination. My heart is heavy. He was exhausted. Partly he was exhausted because he had no support. Partly he was exhausted because he was in an environment where the idea of treating HIV somehow stigmatized you as a physician. This is the Greenspoon article defining doctor burnout. Burnout among doctors generally described in terms of the loss of enthusiasm for one's work, decline in satisfaction and joy, an increase in detachment, emotional exhaustion, and cynicism. I've been there. It manifests as disproportionately high rates of depression, substance abuse, and suicide, and annually 400 physicians take their own lives in the United States. Severe and worsening epidemic of burnout in the United States. And this is one paper looking at burnout, but you look at the base rate, it's almost 40%, and it's gone up between 2011 and 2014. It's gone way up by different studies since 2017 and 18 as people really started to suffer during the COVID epidemic. Been a huge increase in physician burnout during that time. And you'll notice the population rate hasn't changed much, but ours is going up compared to the general population. Other studies show this same thing. If you look at people who are burnt out from work, this is a study in inpatient day hospitals for people with depression and job-related burnout. 89% of people get diagnosed with an affective disorder. That means their brain has stopped making that transmitter dopamine that gives you the yeah from things. That yeah that you get from stuff is one of the things that keeps us going. The average length of stay off of work due to illness was 13 weeks in these people. That's a lot of time to miss. So depression leads to burnout. But what leads to depression? So this is a study of anesthesiologists and laboratory medicine doctors. That was a really cool study. If you've never seen this, you should kind of look at this study. They took pictures of people at time A and time B and cut the pictures up so you can only see the upper part of the face or the lower part of the face or one quadrant of the face, and showed them to standardized audiences, and then looked at telomere repeats at oxidative stress and at superoxide dismutase activity, all measures of stress. And what you found is the anesthesiologist had more aging in their face, upper and lower face, more telomere repeats, more oxidative stress, and decreased superoxide dismutase activities, all measurements of stress. Anesthesiologists are stressed. They're stressed by the increasing emphasis on time, on pressure to get things done, and on doing them cheaper. And they have more burnout. So stress, which in many other studies is known to increase depression, increases burnout. And what causes stress? So there's this model of depression called the repeated social defeat model. And so here you have two rats. One is the bullying administrative rat, and one is the bullied clinician provider rat. And can you play this? So this is mice, but it's the same thing. So the little black mouse is the doctor mouse, and the big white mouse is the administrator mouse. He's bullying him constantly, and he won't leave him alone. And after a while, believe it or not, the little black mouse gets depressed. And so when you continuously bully the little black mouse, he stops being interested in sugar water. Normal mice like sugar water. Depressed, bullied mice don't care about sugar water. They just look for early retirement. And this is D1 receptors, the dopamine receptor in your brain that gives you a yeah from things. I studied D1 receptors at a time when only people were studying D2 receptors. They all said D1 receptors are physiologically irrelevant. I thought, your brain has a very carefully distributed set of totally physiologically irrelevant receptors? That seems weird to me. But it turns out that D1 is really important, and not having any means no yeah and no working hard to get sugar water, which some of you know is important. So social defeat will cause stress, which will cause depression, which will cause burnout. So what is the social defeat? People have used this term, I don't know if you've seen this in literature, moral injury. Moral injury is where the people around you are pushing you to do something that you know is wrong and you're compelled to do. So what is the social defeat? One thing is we're responsible for the outcome of our care, but we have no authority over the resources, administration, or goals of the institutions we work in. You have no authority over it. The institution says, let me tell you what the goal of my institution seems to be. At every meeting, we talk about the length of stay. I don't have any control over the length of stay. I don't have a bunch of people in the hospital who are ready to go home, but I'm keeping them there because I just don't care. If you give me harder patients, they have longer lengths of stay. I'm at Hopkins. We're supposed to take care of harder patients, and therefore we have to have longer lengths of stay. There's no new technology that makes me get people better faster. There's no new magical treatments that make people, there's no new diagnostic tests that allow me to do it faster. Nothing allows me to do it faster. The only way I can make it faster is by delivering less good care. And that is morally injuring. We have no authority about the metrics of our outcomes. Patient satisfaction, I didn't pick that as an outcome. I think being alive is a good outcome. That's a good outcome. If you look at the HIV outcomes before I went to the HIV clinic in 1986, and after I came to the HIV clinic in 1994, I've saved millions of lives. We are increasing regarded as labor by our institution. So at Hopkins, there's people running around with tags. You get your name tag either says doctor or it says management. What's the opposite of management? What's the opposite of white? Yolk, not black. So the idea that we are labor is a big problem for us. And there's a fallacy that all doctors are equal and expensive senior doctors can be gotten rid of with inexpensive or less expensive junior doctors with the same outcomes. We do learn something over time, I think. And there's some data to support me on that. There are a bunch of factors that undermine your autonomy. Mega corporations that form the nucleus of the new medical industrial complex, governmental regulations and DRGs that impede clinical autonomy, guidelines that drive you insane, other professions or would-be professions that provide service at lower rates, litigation and CYA testing and interventions, and the proliferation of administrators directed at the bottom line, gaining compliance, and ridding organizations of intractable members. I won't mention any intractable members in this room. We're sitting at this table right here. I expect any minute the government to call a strike on that table. This is a study, this is a paper by Evans and Reed. Bureaucratic protocols based on cost containment seek to homogenize heterogeneous conditions and events. And basically, this is a description of how guidelines and saying all cases are equal and all problems are equal and all clinicians are equal is used to distort what you do. This is Burnett's paper on restoring medical professionalism. The essence of medical profession is dedicating the welfare of the patient above anything else. That's the doctor-patient relationship, the clinician-patient relationship that is at the core of our relationship with our patients. And it's distorted by conversion to a business model, addition of intermediate financial control, and this increasing consumerism we see, where patients come to us and say, this is what I want, give it to me. And I say, it's not good for you. They say, you're supposed to be making me feel good. Give me my Klonopin. And I say, well, Klonopin's bad for you. I think Klonopin helps me. You live in a refrigerator box. You have no friends. You have no job. You have no place to live. You have no activities in your life. I think you've done a good therapeutic trial of Klonopin, and it's not working. These conversations are difficult for us, but they are essential to what we do. And this is a Robert Bowles' speech to the Illinois Medical Center. The amenities of professional intercourse and the obligations of men toward each other and the public were perhaps better observed in 1850 than now. The doctor was trusted and a counselor for every family. Every passing year added and cemented the attachment and affection. The doctor is now regarded more as the light of a tradesman or a mechanic and is employed for the same consideration that a grocer, a trailer, or a shoemaker is. The relationship is placed on a mere commercial basis. And for this, the profession is more to blame than the public. Now, he gave this speech in 1890 or something. This is an old problem, not a new problem. There will always be people who want to prevent you from doing what you think you should do because of economic issues, because of diversion of resources, and because if medicine makes a lot of money, that money should not go to you or to care, that should go to us. That's natural in any business where people want to make profit. But we're supposed to be immune from that because we are a service and not a business, which is why we're nonprofit. This is Sir Graham Cato's statement at the General Medical Council when they were debating the future of medicine. And he said we could be moving away from roles, doctor, nurses, and move towards practices. And people would be practiced not to practice medicine, but to perform appendectomies or fetal ultrasounds. And it wouldn't matter if you're a nurse or doctor. I don't think that people should be as inflexible as they have. And this is based on the theory you don't need to know about the internal combustion engine in order to be able to drive. In clinical practice, doctors trained this way do not perform any less well. That is nonsense. You don't have to know physiology, anatomy, or pharmacology to be a doctor, to be a provider. You just have to know how to drive. Can you follow the guideline? You're as good as anybody else. That's the most insane thing. And yet this guy is the head, he was the president of the UK regulatory body for the General Medical Council, saying this. You want a doctor who's thinking about your case. Pay for performance. They want you to pay for performance, such as airline on-time performance. This is straight out of the literature and based on measurements of patient satisfaction and experience. If the patient is satisfied, so it's going to turn out it's more important to fluff the patient's pillows in terms of getting paid than to get the patient better because they have better experience. And I've had patients who complained about me because I wouldn't give them IV Dilaudid on the pain service. You came in because of the Dilaudid. I told you when you came in we were going to get you off narcotics. Of course I didn't give you Dilaudid. The goal was to get you off Dilaudid. Well, I'm still angry. In the midst of all of this problem, we drop in EPIC. I'm just going to look at the last part of this slide. For every hour physicians provide direct clinical time, nearly 2 additional hours are spent on the EPIC or EHR and desk work within the clinical day. Outside of office hours, physicians spend another 1 to 2 hours of personal time each night doing additional computer and other clerical work. My wife comes home, gets on her, she's a family medicine doctor, she comes home, gets on her computer, and does computer stuff for 2 hours a night at least. I refuse to do that. I get on the computer and look for things to send SAG that are funny. We have to resist this. So this is 2012. This paper came out in Archives of Internal Medicine. I show it every year for the same reason over and over again. It showed that increased patient satisfaction correlates with increased mortality. 50,000 patients. It was a real paper. And they wouldn't publish it initially because they said that the reason that happens is because the sicker patients have more of a relationship with their doctor and therefore more satisfied. So that turns out not to be true because if you look at the patients in good health, it's more effective. If you give the patient what they want, they die. If you give them what you want, they may be dissatisfied, but they live. And I think that what's driving this is not all the patients. It's a small subset of patients. The subset of patients who are injured by an emphasis on patient satisfaction. They are patients who think that they can use patient satisfaction to extort you to give them things that are bad for them. At the same time that this is published, 6 months later, Medicare says they're going to base hospital payments on patient satisfaction. In the light of this paper, well, it's something we can measure. Not necessarily a good thing to measure. The opioid crisis contributed hugely to physician burnout. Many physicians feel that primary care practices are in a never-ending game of whack-a-mole as they answer to a growing cadre of masters, faceless managed care bureaucrats, managers, IT consultants, quality measurement gurus, and patients. As time grows scarcer and rewards grow leaner, the excellent physician, while managing one's life outside the house, has been increasingly challenging. I agree with that. It's increasingly challenging to be an excellent doctor. However, being an excellent doctor is the antidote to burnout. Doctors are pressured to prescribe opiates. This is from 2016. After everybody was saying you shouldn't prescribe opiates, doctors were still being pressured by administrators, 2016 study, to prescribe opiates based on administrative and regulatory criticism, Joint Commission negative impact, and patient satisfaction scores. This is drug overdose deaths through 2018. It's actually gone up since 2018 during COVID. Overdose deaths went up by quite a margin. In 2012, on this graph, we said we should stop prescribing opiates. When we stop prescribing opiates, what happened? The death rate accelerates. It accelerates because we didn't say, how are we going to get people off opiates, run programs for every physician on how to transition people off the opiates onto more effective pain management syndromes, and instead we just stopped giving it to them. And when we stopped giving them opiates, after addicting them to opiates, they went out and used opiates. And this injures us morally because we watch our patients die while following guidelines. This is drug overdose, all ages. What you can see is in the red line is synthetic narcotics like fentanyl, mainly fentanyl. Between 2015 and 2018, shoots up. Of course it shot up. And of course people started to bring in fentanyl. We stopped giving people their oxy that we had put them on. These are headlines of all kinds of things that pressure you every day. Doctors fired for criticizing his hospital over their coronavirus response, speaking about safety in coronavirus, elderly patients with possible COVID suing, and hospitals tell doctors they'll be fired if they speak out about the lack of gear, and all these other things. One Idaho doctor was fired after wearing a mask in Boise. These things are pressures on us to do things that we think are wrong and injure us morally. And we have no coherent voice to respond. This is from William Osler. You are in this profession as a calling, not as a business, as a calling which extracts from you at every turn self-sacrifice, devotion, love, and tenderness to your fellow men. Is not compatible with length of stay pressures. This is from Robert Louis Stevenson's preface to Underwood's. He is the flower of our civilization. Generosity has discretion tested by 100 secrets, tact tried in 1,000 affairs, and more important, Herculean cheerfulness and courage, so that he brings into the air and cheer into the sick room, although not often enough as he wishes, brings healing. This is what we're supposed to be doing. This is why I went into medicine. This is why all of you went into patient care. So you could be this guy, this woman. My wife's this woman, by the way. So who do we work for? Do we work for the patient? That's what I think. Do we work for the state? Euthanize and sterilize the mentally ill? Promote physician-assisted suicide and euthanasia? Do we work for the hospital and shorten our length of stay? Do we work for the insurance company and decrease their expenditures? Do we work for the American Pain Society, which said pain is a vital sign? Pain is not a vital sign. I was a physiologist in a lab. Vital signs are when you're alive. No vital signs, you are not alive. Pain is not a vital sign. You can have pain and be alive. You can't have pain if you're dead. But you could be alive with no pain. You can't be alive with any other vital sign. If you have no breathing, if you have no pulse, if you have no blood pressure, you're dead. If you have pain, you're alive. But if you have no pain, you're also alive. That's not a vital sign. And yet, huge numbers of people pressured you to call pain a vital sign. Pressures that physicians that conflict with their performance of their duty, length of stay, P&T committees, I'm on the P&T committee at Johns Hopkins. It's a conflict of interest. Pressure to keep patients satisfied, medical legal pressure, bioethics for hire, and assisted suicide and euthanasia, which turns out to be a very inexpensive way to solve problems. Burnout is in part a product of allowing others to define our jobs and our goals. Other person, I won't mention the name, you are disagreeable, Dr. Treisman. Me, I am not disagreeable. I disagree with you. The rhetorical, by the way, there's a name for this specific rhetorical technique of making you disagreeing with somebody into a problem with your personality rather than your commitment, rather than your integrity. I use the word integrity. That upset that other person. Ways to avoid burnout: eradicate smallpox, restrict polio to 3 countries, stop HIV progression, cure hepatitis C, cure hepatitis B. These are things that avoid burnout. I get people better that no one else can get better. I get a huge kick out of it. Sokowski calls me and says, can you help me with this patient? I do. The patient completes their hepatitis C treatment and is cured. I get a big kick out of that. This is, you know this is the HIV-1 remission in the first patient, and this is the second patient. And the take-home message, put your own mask on first. If you're burning out, get help. It is not embarrassing to come and see me or one of your other colleagues and say, I'm in danger of burning out, and that would undermine the care of patients at this center. I don't want to burn out because my patients depend on me. Help me with it, and we will. I help people with this every day. People can help you with it. Don't let them burn you out. Responsibility for outcomes always falls on you. If it doesn't go well, no administrators come to court and say, I told Dr. Treisman to discharge that patient early. It's really my fault the patient died. That's not going to happen. They're going to say, well, he's the doctor. Now, while the patient's in the hospital, they will come and say, you have to discharge this patient. They've been here too long. We're not getting paid for it anymore. You discharge the patient, then something bad happens. They don't go to the family and say, oh, we made Dr. Treisman do that. You are responsible. Take the authority. At least I can just tell you, in an N of 1, nobody has fired that person for having a long length of stay. Burnout is not because our job is hard. You are completely unafraid of a hard job. Completely unafraid. You went into HIV care and hepatitis C care and hepatitis B care. You are fearless, and you're not afraid to work hard. It's not because it's hard. It's because it's frustrating. The term moral injury is big in the literature right now. It's described the injury to you when you're pushed to do the wrong thing. And I avoid burnout by doing the right thing, even when it means I'm disagreeable. And you're going to have to disagree with some people in order to keep going. You're going to have to disagree. He's not afraid to disagree with him. He's not afraid to disagree with him. But as a group, we are afraid to disagree with the administrators. And at some point, you'll have to. However, I've been doing this for 35 years, and everybody said, you will burn out if you do HIV care. Everybody said it. My chairman was worried I would burn out. The 2 psychiatrists who went to the HIV clinic before me both burned out, as did many other doctors. I didn't burn out because I got people better. I didn't let anybody tell me how to practice medicine. I learned how to practice medicine by doing it, as you have all learned to do. And when people tell you how to practice medicine, especially if they didn't go to medical school, especially if they have no experience doing what you're doing, don't listen to them. Do it the right way, and you won't burn out. Thank you.
Well, I'm going to invite our speakers up and extend my thanks to Glenn for that discussion of burnout. I might be so bold as to posit that coming in person to OPMAN is also an antidote to burnout. I mean that in part because there is something that we're losing with Zoom, and interacting with people who are shared mission really is inspiring. And I know I leave this meeting and show up to work on Monday a bit inspired because of that. So thank you for those important discussions and topics. So we do have some time for questions. We will try to break on time, so maybe cutting a little bit short, but let me go to the microphone. Yeah, I'm sorry.
It's fine. I was wondering if you could speak a little bit about social pressure, like, you're talking about the burnout coming in from kind of the organizations that we're working with, but burnout coming from social pressure. I'm thinking cannabis, I'm thinking HRT, I'm thinking Ozempic, all these things that this is, what I mean.
Yeah, I think that one of the things I mentioned is this idea that we are in a commercial relationship with our patients. That is, we're supposed to provide what they ask for, what the culture says is important. We're supposed to do what patients tell us, what society tells us. And that is a huge pressure on you. For instance, right now, marijuana is regarded in many states as a medication. There are no FDA indications for marijuana for anything. There is almost no evidence for marijuana as a therapeutic agent providing benefit over time for anything. Maybe infantile seizures, but that's probably not why you're giving it to your patients. If you write a prescription for medication, you have to see the patient back for follow-up. If you give them a marijuana card, you never have to see them again. And you can get your marijuana card without seeing a doctor, just going online and chatting with somebody online. You can have a marijuana card. That's not how medication works. And yet you are being pressured right now to give people marijuana. And it turns out, believe it or not, there's a little financial incentive to make marijuana into a medication and approve it for everybody. Not only do you get your marijuana, you get it for free. No therapeutic. I can't get hepatitis C treatment for people free without making 50 phone calls. Marijuana, no problem. So those kinds of pressures are very exhausting. And if you keep your eye on the ball, that is, you think, what does the data really show? What does my experience really show? Have I seen lots and lots of people I couldn't get better get a marijuana card and suddenly they are better? Have I seen that? Those are the things that guide us in these difficult times. And euthanasia-assisted suicide, massively financially remunerative. So lots of countries are pressing people to be euthanized rather than expensive tests and expensive medications. It's not part of our job description. If you go in there with a little black bag and death is in the bag, but also penicillin, people will be uncomfortable with you. I might give you some penicillin, but I might just kill you. It might make your patients a little uncomfortable. So we have to be very careful of our purpose, which is to promote life and health and to make people comfortable if there's nothing else we have to offer, but to make them comfortable.
Well, great. Let me see, looking across the room, some other questions. Ken, let me go to a question to you. Hepatitis D testing is somewhat difficult to get. So for example, in our EMR instance, we can't access it if the patient is using LabCorp. There's no antibody availability. And then RNA testing, particularly quantitative RNA testing, is impossible to get unless I type in a special request to the lab to send it out. It's really hard to get. So talk to me about just to, if we're going to be testing for more people for D, and then, talk a little bit more about just the pragmatic aspects of testing.
Yeah, I think that your experience is pretty common across much of our healthcare system. It is hard to get hepatitis D testing. We have pretty efficient send out for the antibody. The RNA and a quant RNA is quite difficult to get and takes a lot of work, the burnout work that Glenn talks about. And yet we're going to have to do better if we're going to have medications that we're going to prescribe, not for being antibody positive, but for being RNA positive. So we need to fix those things in our system as well.
Yeah,
I was going to ask you the same kind of question, but a little further. As a specialist who does HIV and hepatitis C care, hepatitis B care, and increasingly I make the diagnosis of these things up on the inpatient service. If someone has hepatitis B and I think they have virus, should I be testing them for D, or is that something I should send them to someone to do, knowing that they probably won't get it?
I think if you can do it up front, it helps us. So I would say, sure, order the appropriate tests. That's being a good physician.
so we talked.
See?
We talked about this quite a bit with hepatitis C over the years, of getting the antibody followed by a reflex RNA test. And I think what Ken is describing is the need to get there for D as well. You showed that slide of people with HIV. The number of antibodies was here. The number of people who had antibodies with viremia was much lower, and yet that testing is hard to obtain right now. So,
Although I think that if we pressure people to do what you did, which is if you get hep C, we have a reflex viral load now. If you have the antibody, it's one test, and it automatically does it reflexively, like sending a urine culture if you have a positive urine, and that test should be put into the orders.
But even for hep C in my system, it took us probably 5 to 7 years to get that reflex testing done in the lab because the lab administrators fought against it.
Of course.
which brings me to a point, Jordan Feld made the point about which patients you might want to stop on nukes, and it required you to measure the S antigen level, which is something that's not routine. linking that to Glenn's talk, it took me 2 years to get that available in our instance of EPIC so that I could order a quantitative S antigen level. So I did get a little demoralized during that 2-year process, but then suddenly it emerged and now I can order Quant S, which is, but so I imagine we have to do these same kind of things. And Jordan did make the point that quantitative S antigen is not widely available. And we're gonna, if we do get to the point where future treatments and or decisions to stop treatment are based on how much of that viral protein's in the blood, we're gonna have to get the diagnostics easier. A source of frustration for clinicians. Ken, are you routinely doing S antigen levels on all your patients with B and then those with D?
No, it's not been a routine part of our practice because at the end of the day, it tends to not affect the decisions that we're making with the current medications. It may affect the decisions going forward, but we're not there yet. It is something we need to get in place. We can get it from outside, but not internally.
Well, let me ask you a question about management of D, because I had a patient recently where I said to myself, if the S antigen level is low, maybe I'll try interferon for a person with B and D. And I don't know if that was the right way to think about it. It turned out to be really high, so I abandoned interferon. But do you think it's any use there, the quant level, to predict who might respond to interferon?
Yes, it will help in predicting, but because of the injury associated with levels, I actually would treat everyone regardless if that's your only agent available.
Yeah. So no role quite yet on SA unless you want to follow the notion of stopping nukes, which I do want to just comment. There was a question we didn't get to about those patients do need to be followed very closely in clinical practice because of the potential for a rapid rise followed by flare. So if you're going to try that in practice, I talk to my patients about it. Most of them say, wait, you want me to get labs at least once a month or every 2 weeks? No, thanks. I'll stick with every 6 months and stay on my nuke. We got a question at the microphone right in the back there.
Yeah, so this question is mostly surrounding the level of burnout. I'm actually really blessed to get to work. I'm a pharmacist, and I'm blessed to get to work with 18 ID physicians and 1 amazing ID PA. However, because of our Ryan White funding and 340B funding, all of our providers have to see patients living with HIV, and although I'm super passionate about that care and I love that, and that gives me the yeah factor. We do have a few physicians that's not their thing. That's not their jam. It doesn't give them the yeah factor. So is there any evidence or reports or anything surrounding physician burnout, kind of surrounding that they're seeing patients that they don't necessarily want to see, and how do we move forward fixing that? Like, I feel very passionate after this talk to go back to my clinic and say, let's help these providers not have to see patients that is not their yeah factor. But is there any evidence surrounding that?
Well, so there isn't good evidence specifically about any of these sub-factors. There's only evidence about what physicians complain about, what providers complain about. 'Cause it's not just physicians, it's all providers, pharmacists as well. One of the things that burns people out is the frustrations of having obstruction put in their place that's purely administrative. That is, there's an FDA-approved indication for this drug. It's not even experimental. It's clearly indicated, and it's blocked by needing prior authorization. That just puts a burden on you, so hopefully you won't do it. And that is exhausting for people in general. Having said that, in my own perverse personality, I get a huge kick out of trying to burn the administrators out by going for a prior authorization, even if there's an equivalent drug. I go for the drug I picked because I think if I pick that drug, it's probably better. That's what my prejudice was, that this is a better drug, and I'm going to get it, and I'm going to ruin your life for ruining my life with efforts to get the prior authorization. I go right up the chain. I call the medical director, whatever I have to do. It's very irritating to them because the thing that was designed to get me to stop doing it, I'm doing it more. That keeps me from burning out. I don't know if it'll keep any of you from burning out because it's purely anecdotal. But the data is, over time, is that if you aggravate them enough, they will make the hepatitis C reflex thing just so you'll go away. And they will authorize your patient being in the hospital just so you'll go away. I tell families, call the governor, the insurance commission, your senator, and your congressman of your state and say the insurance company is trying to misuse you. Person needs to stay in the hospital. They're at Hopkins, blah, blah, blah. And those people start calling, and the insurance company, okay, we'll give you a couple more days. Okay, thank you, that was good. But it aggravates them. Aggravate them back.
Yeah, I have to say I can relate to that. I just won an approval for a Hep B therapy. It's not for alphenamide. It had been denied. Took me 3 months, but we just got the approval. Victory for me and my patient. It did feel exciting to win that fight.
The other thing I will say is you want to have a good patient-doctor relationship. When you advocate for your patients to get these medicines and you tell them, I'm going to get this for you, and you get it for them, they will take it more. It was hard fought to get you this medicine. They will take it. It's you and them against the system now. And that is a very, very good way to develop patient-doctor collaborative work or patient-provider collaborative work. You got them the medicine, you fought the system, and now you're going to get them better despite the effort to try to keep them sick.
Well, so maybe we'll stop there. We're going to go ahead and get started with our next two lectures in this morning session. So we've got 2 talks, then we'll have case presentations on a working lunch, followed by the roundtables. So I'm really thrilled to invite Jordan Lake to the podium. She's going to talk about what is a growing problem. In fact, many of you who joined us yesterday know that this topic of obesity and metabolic disease was a prominent feature of what we talked about in the management of people with HIV. And Jordan's been doing research and work in this area for a long time and really writing some of the literature that's helping us better understand how metabolic disease and HIV intersect. She is from University of Texas in Houston, McGovern School of Medicine, and we're really thrilled she's joined us and welcome her to the stage. Jordan?
Thank you. And good morning. This is a huge topic, by the way, so I am going to try to cover as much as we can. I wanted to give you a good flavor of the full spectrum of disease. No relevant disclosures. So our objectives, we're really going to talk about epidemiology and definitions for non-alcoholic fatty liver disease and metabolic-associated fatty liver disease. Talk about how traditional risk factors as well as ART and HIV specific risk factors are contributing to fatty liver disease in our patients with HIV. A little bit about special subpopulations, and then finally a quick overview of available and upcoming treatments. So as most of you probably know, fatty liver disease is defined as having greater than 5% of hepatocytes with an increased lipid droplet size on biopsy. As technology has evolved, the definition of greater than 5% fatty infiltration of the liver on imaging has also now been an accepted definition. And if you look at the literature, about 30% of US adults are thought to have NAFLD, and if you add on other metabolic comorbidities like diabetes and obesity, this really goes up to almost complete saturation of fatty liver disease. In the setting of HIV, when the estimates are up to 50%, and that's all comers, so this is including lean folks, those who don't have specific risk factors for fatty liver disease. And the reason I'm telling you this is because it's thought that perhaps people living with HIV have increased prevalence compared to the general population. And not all studies show this, but I think there's enough accumulating evidence that we can pretty confidently say that's true. So just to jump right in with the audience response questions, which of the following is not a known risk factor for fatty liver disease in people living with HIV? Okay. So I would say none of the above. Okay. So we'll talk about it all, but there's some data that was recently published from a multi-ethnic cohort of almost 350 adults with HIV seen throughout 3 clinics in the United States. And in that cohort, the prevalence of fatty liver disease and NAFLD were 49% when you were diagnosing by ultrasound and 51% when you were diagnosing by transient elastography, as defined by steatosis being a CAP score of greater than 263 decibels per minute, for those of you who are familiar with the transient elastography cutoffs. Almost all of that liver disease was non-alcoholic fatty liver disease. A very small proportion was alcoholic liver disease, and the study had excluded by design people with viral hepatitis induced liver disease. So NAFLD was a huge problem and highly prevalent in this cross-section of adults with HIV. And something really notable, and that we'll talk about more later, is that 33% of the people who were diagnosed with hepatic steatosis had a BMI less than 25. That is huge compared to the general population estimates for lean NAFLD. And in multivariable analysis, only traditional risk factors were associated with NAFLD prevalence. So we have to think about, in the setting of HIV, what's the same when it comes to hepatic steatosis and what's different? There's no question our traditional risk factors, obesity, diabetes, alcohol, older age, and when I say older, the prevalence of NAFLD goes up dramatically over the age of 40. Those are major risk factors, as are viral co-infections. This is going to be the greatest contributors to risk in your patients. That being said, there are antiretroviral therapy specific effects, and there are virus specific effects that are unique to people living with HIV that also contribute or may exacerbate disease. And particularly in folks with lean NAFLD, these non-traditional contributors may really be playing a bigger role. So this is just a generic list of risk factors that are associated with hepatic steatosis in the general population. You can see HIV itself is down at the bottom as one, but I put a star up by insulin resistance because almost all of my patients particularly have in one or all of the factors listed there contributing to insulin resistance, and that really is a major cardiometabolic consequence and supporter of fatty liver disease in our patients. We have to talk about obesity. Generalized obesity is prevalent and important in our patients with HIV, and these are data that are old now from patients in the southeastern United States, but even at this time, about 50% of people presenting for ART initiation were already overweight or obese, and within the first 12 months of ART therapy, the prevalence of being over a BMI greater than 25 increased to 65%. This is certainly what we see in our clinic in Houston. We have well over 50% of patients with BMI over 30. And so generalized obesity, in addition to any other contributors to fatty liver disease, is going to be a major player. And I'll say this is also prior to the era of a lot of widespread dolutegravir, bictegravir, and tenofovir alafenamide use. So when you're thinking about weight gain with antiretroviral therapy, this is probably even a modest estimate at this point. And we know that obesity leads to fatty liver disease. So this schematic shows you the lipid overflow hypothesis for how fatty liver disease develops, such that your adipocytes will store fat in their lipid droplet as long as they can, but at some point there's actually a physical limit to how much they can store, and when they reach that capacity, fat has to be stored in other places, and it's stored throughout organs of the body, but particularly in the liver, we see cardiometabolic consequences from that. And in addition to generalized obesity, one thing that we're worrying about specifically in our patients with HIV are that fat gain and lean loss seem to be the rule of aging with HIV. And so these are data from the monometabolic cohort with women in the dashed lines and men in solid lines, and ages broken down there that you can see. But overall, on the left, in patients who were already on antiretroviral therapy and stable, when they were followed for up to 10 years with serial DEXA scans, everybody was gaining fat mass, and everybody was gaining fat mass at a rate that was greater than expected for age. Similarly, on the right-hand side, everyone was losing lean mass at a rate that was greater than expected for age. And this is particularly worrisome in the youngest patients who were losing lean mass. But it makes you think that we are potentially barreling towards an epidemic of sarcopenic obesity amongst people living with HIV. And we know from the general population that sarcopenic obesity has mortality consequences separate from just generalized obesity. These are other important drivers of fatty liver disease in people with HIV. I'm going to go through a lot of them independently, but you'll have the slides to look at the figure more closely on the left to try to see how these things all fit together. We do want to talk about the role of the virus. So the VPR mouse model gives us a real window into what are virus-specific effects on metabolism in people with HIV. And what happens in the VPR mouse model is that through diet, they are able to activate gene expression of HIV viral protein R in specific tissues and then follow to see what are the metabolic consequences of just having that protein in the body. So unlike a lot of mouse models, this does not require active viral replication. And I think that that's really relevant when we're thinking about consequences and virus-specific effects in people with HIV, because as you would anticipate, there is virus throughout the body that is not actively replicating. And until we are able to truly flush the body of virus and cure HIV, there will be viral persistence in tissues. And so here you can see when they induced VPR expression, the mice develop hypertriglyceridemia as seen on the left-hand panel of the figure, and they also develop hepatic steatosis as defined by oil red O staining seen in the right-hand panel. And while they're developing hepatic steatosis, their ALT levels also go up. So these investigators were able to further work out the mechanisms, and indeed VPR specifically stimulates de novo lipogenesis, it reduces fatty acid oxidation, and then it reduces fat export out of the liver, which all lead to increased hepatic accumulation of fat. When we're thinking about antiretroviral therapy, stavudine is the main culprit historically. What we don't think, however, is that stavudine itself has a legacy effect on hepatic steatosis in that there is some reversibility. But what does have a legacy effect are sequelae of thymidine analog NRTI exposures. And when I say that, we know both AZT and D4T cause significant mitochondrial toxicity and lipoatrophy and fibrosis. And mitochondrial toxicity continues to affect liver and fat function well after removal of the offending agent. And once once lipoatrophy has occurred in the subcutaneous tissues and fibrosis has set in, that really limits the buffering capacity of the individual adipocytes to store fat. So the body then preferentially has to store fat in the viscera. So this legacy effect of the thymidine analogs is probably a fair contributor to fatty liver disease in folks that have had that exposure in the past. And then, of course, our currently preferred agents are associated with greater weight gain than some of the older regimens, and so these likely modify hepatic steatosis risk through weight gain. Microbial translocation is a known driver of fatty liver disease in the general population. We know that gut barrier breach occurs early after HIV acquisition and is persistent on antiretroviral therapy. And so when you have gut barrier breach, microbial products get into the bloodstream and they are drained through the liver and through the surrounding adipose tissue. And this is highly inflammatory to the liver. So exposure to microbial products cause in the liver and adipose tissue all of the inflammatory and immune activation pathways that you see there. It causes disturbed wound healing. It causes basically constant organ stress. And this is believed to contribute to the development of fatty liver disease. Again, microbiome changes in the general population have been associated with fatty liver disease development and progression. We also know that obesity is associated with microbiome changes and HIV is associated with microbiome changes. How these all intersect really has not been worked out, but I think that it's fair to assume that there is some interplay in people living with HIV as well. And hopefully future research is going to really dissect that a little bit better for us. I always have to mention some factors that may be specific to our transgender women living with HIV, but what I'm actually going to tell you is really relevant to any person on estrogen supplementation or your cis men who are hypogonadal and not fully repleted with testosterone. So we know, again, from general population that testosterone deprivation is a risk factor for fatty liver disease, and that, in fact, is a goal of feminizing therapy for trans women. Similarly, in cis women, estrogen deprivation, whether pharmacologic or through menopause, increases the risk of fatty liver disease. So, you know, which is it? Is it testosterone? Is it estrogen? Is it the ratio? For our trans women, that certainly hasn't been worked out. But we know estrogens cause weight gain. They increase triglycerides and glucose. These are all risk factors for development of fatty liver disease. If you're also taking progesterone, which is not recommended by the guidelines, by the way, but many patients seem to acquire from their providers, this causes additional fat gain that's amplified in the presence of estrogens, and so that may be an additional risk factor. Spironolactone, you know, through its many uses in general medical practice, but it peripherally converts testosterone to estrogen and stimulates the glucocorticoid receptor. So it's very possible that spironolactone use, especially high doses in our trans women, are worsening insulin resistance through visceral fat accumulation. And this could be relevant to any of your patients taking spironolactone for any indication. Also, finasteride is one of the most commonly used alternative anti-androgenic agents in the United States, and it blocks conversion of testosterone to DHT, so that sort of promotes the androgen deprivation scenario. And then finasteride also causes a lot of metabolic changes that, again, are thought to be associated with fatty liver disease development. So do a lot of the medications that we provide, not only to our trans women, but all of our patients with HIV contribute. Okay, so I talked a lot about risk factors. Who should be screened for fatty liver disease? Great. All of the above is also my answer. I would argue that most of your adult patients, it would be reasonable to screen. However, I realize that's not practical in clinical care. So the US has not yet, to my knowledge, released guidelines for fatty liver disease screening that are specific to people living with HIV, but the European AIDS Society has, and you can see here their algorithm. And what this algorithm is really focused on is who is likely to be started down that pathway of progression to advanced liver disease. And so they recommend starting with a non-invasive score, determining who is at that higher risk, and then moving towards imaging or hepatology referral, et cetera, from there. But I think it's important. There are two categories of preventable sequelae with fatty liver disease. There's progressive liver disease, which is certainly important, but there's also all of the cardiometabolic disease that is associated with fatty liver disease. And when we're thinking about treatment and prevention, I think we need to think about both of these categories. And so this algorithm you're probably familiar with, this shows that in the general population, a minority of people progress all the way from having hepatic steatosis through the traditional non-alcoholic steatohepatitis pathway towards fibrosis and end-stage liver disease. But we know from cross-sectional and now longitudinal data that there are higher rates and greater severity of NASH in people living with HIV. And you can see here this, in this cross-sectional study, this persisted when adjusting for some traditional risk factors. And then recently longitudinal data has come out that shows that progression through that spectrum towards end-stage liver disease is also more rapid in people living with HIV. So we really do need to think about the possibility for accelerated or more severe liver disease, which should heighten our desire to screen patients. And then simple steatosis is this term that gets used, again, when you're thinking about the traditional progressive liver disease pathway where somebody has hepatic steatosis on a biopsy or on imaging, but they don't seem to have any immediate sequelae as it relates to the liver. but I'm not sure that simple steatosis exists when it relates to cardiometabolic sequelae. And so these are just some data that were presented at CROI last month, showing specifically in people living with HIV that within 4 years of being diagnosed with NAFLD, compared to not having NAFLD in blue, those with NAFLD with or without NASH were more likely to develop diabetes. So these data aren't surprising, but these are some of the first HIV specific data that we have showing risk of specific cardiometabolic risk that's longitudinal. And we know fatty liver disease is associated with cardiovascular disease. We don't, have to go through all of that, but this figure is really to show that fatty liver disease not only promotes a lot of the cardiometabolic disturbances that lead to cardiovascular disease, but then if you have those are also reinforcing towards fatty liver disease. And so you get into this cycle that's very difficult to break that ultimately leads to increased cardiovascular risk. And you have the slides. I won't read to you all of the risks here, but one example is, again, from the general population, we know in the bottom right-hand corner that having significant or more moderate to severe NAFLD is associated with a 2.6-fold increase in fatal and non-fatal cardiovascular events. So significant relationship. Okay, what is metabolic associated fatty liver disease? That was in my title, so we have to talk about it. Okay, my answer is C, fatty liver disease co-occurring with diabetes and or obesity. And so that's by the strict definition, though those of you who put ANC with a subsequent diabetes diagnosis are not necessarily wrong. But here is the official algorithm for how you diagnose metabolic associated fatty liver disease. So this is taking adults, again, in the general population who've been diagnosed with hepatic steatosis. And then if you're overweight or obese or you have diabetes, you automatically get put into the category of MAFLD. If your BMI is under 25 and you have the risk factors listed below and you need at least 2 of those risk factors, then you also would qualify as having MAFLD. I think it's easy to see from this list, many of your patients have at least 2 of these risk factors. So there's a huge amount of people with hepatic steatosis who would meet the definition for MAFLD. But why is there a new definition? This is my personal opinion. A lot of it is semantics. But I think that naming this differently really aims to highlight the primary drivers of NAFLD and asks people to think about hepatic steatosis in a more holistic way and not only with a progressive liver disease focus, to really think about those cardiometabolic effects. And, not all NAFLD is MAFLD, certainly, and similarly, you can have fatty liver disease from other causes like alcohol or viral hepatitis that co-occur with MAFLD. So it's that first group that we showed here at the top, that's any hepatic steatosis from any cause, not just non-alcoholic fatty liver disease. So I told you I would mention lean NAFLD. That's defined as having hepatic steatosis or NAFLD with a BMI less than 25 for most races and ethnicities, or less than 23 if you're of Asian descent. The global population estimate and the US population estimate is very low. Lean people, just tend to not have the major risk factors for NAFLD in the general population. But you saw from that first data that people living with HIV may have much higher prevalences of lean NAFLD, and we're starting to get cohort data now that will help define that better. And I think this is where some of these unique risk factors play in. And so we need to think about whether or not our leaner folks with HIV also need to be screened. The American Gastroenterology Association did recently put out an expert opinion statement about lean NAFLD, again, for people in the general population, saying that you should start thinking about it in people with BMI less than 25 who have existing metabolic disease and elevated liver biochemical tests, namely ALT. Just like with non-lean NAFLD, lifestyle intervention is the main go-to treatment at this point in time. The only real way that this expert opinion statement differs from regular NAFLD management is that some of these drugs that are thought to improve NAFLD through weight loss like the GLP-1 agonists, their role is not quite clear if you're giving them to a patient who doesn't need to lose weight. So more on that to come. And just briefly, a few words on treatment. This figure here just shows you all of the categories of risks that we already talked about. And I think all of these areas are potential therapeutic intervention points. Still, lifestyle modification is what we have, but as you know from other settings, including obesity, we don't have a ton of luck with getting behavior change and getting sustained lifestyle modification. And then there are factors specific to people living with HIV. We know that dietary habits have been documented to not be great, and more commonly, people living with HIV do not meet those minimum activity requirements that you would want from optimal lifestyle. There have been weight loss studies in people living with HIV. The results are kind of all over the place, but those who did have a successful intervention did show some metabolic benefits. So I think if you can get the person to make those lifestyle changes, you would expect the usual benefits from that. Lots of people ask, can you change your ART and help treat NAFLD? You know, I think we have to think back, and in general, there's been minimal success with ART switch strategies to change body composition, so I'm not sure that it would be different for NAFLD. And for the foreseeable future, integrase inhibitors and tenofovir alafenamide, which have been associated with the greatest weight gain, are going to remain the standard of care for us. But there is this continued worry about people who seem to have excessive weight gain on INSTIs and tenofovir alafenamide. And so these are data, again, presented at CROI last year from the Athena cohort, specifically looking at the percentage of people who gained more than 7% of body weight after starting an integrase inhibitor with TAF, and that was their cutoff for what they defined as excessive body weight gain. And then in the three graphs, you see what happened over 2 years if people were switching off of one of those drugs. And sample size is extremely small, but on average, about 2 kilos, 5 pounds of weight loss over 2 years, not a clinically significant amount of weight loss with an ART switch. But the only data we have right now is observational. And there is a study, AIDS Clinical Trials Group A5391, that will formally evaluate the effects of switching from an integrase inhibitor plus TAF to a doravirine-based regimen with either TAF or TDF. That does not have specific liver imaging, but it does have whole body DEXA, so they will be able to follow changes in trunk fat after the switch. You know, there are many, many things in development for NAFLD-NASH treatment. In people with HIV specifically, there's a little bit of data around benefits of statin. The REPRIEVE trial, which, you know, is a very large cardiovascular endpoint trial for people randomized to pitavastatin or placebo, does have a sub-study where there's dedicated liver imaging on about 800 patients. And so those results will eventually come out, and that will be the largest study in statins in people living with HIV. The growth hormone releasing factor, tesamorelin, hasn't had huge uptake in general for its indication in HIV-associated lipohypertrophy, but there is a small study showing a reduction in MRI quantified hepatic fat with tesamorelin. And then pioglitazone, only one small study in HIV, but you would expect it to have a role in NASH treatment similar to what it does in the general population. This slide is just miscellaneous treatments of things that are specifically in trials for people living with HIV. So hopefully in the next few years, significant data to come. I think the most exciting thing is probably GLP-1 agonism. GLP-1 expression is reduced in NAFLD. It's increased in the setting of HIV, but these agonists may be able to overcome whatever trigger is causing increased GLP, and that study that showed increased GLP was from a very small study of men only. If it improves liver fat, it has the potential to improve liver fat through many different pathways, and so that's one of the reasons it's an exciting agent. I harp on this a little bit because I think that they are potentially very useful drugs, and there's 3 studies ongoing in people living with HIV right now. AIDS Clinical Trials Group A5371 will be the first to finish. And so that is specifically for people with HIV and NAFLD. It will have primary endpoint results this summer. There's 2 other weight loss studies ongoing as well. And I think the one caveat that we have here is all of these studies use 1 milligram weekly of semaglutide. So that's the diabetes dose. It's not the weight loss dose. That's because Novo Nordisk declined to provide drug to these studies, and that was what was available for purchase at the time that these studies started. Now, of course, the weight loss dose is on the market. It's 3 to 4 times higher than the diabetes dose. So whatever results come out of these studies, whether negative or positive, I think there's a fair chance they may need to be repeated with the weight loss dosing now that it's available. So I'm over time. I will end just by saying there are many, many opportunities for research in this area in people living with HIV. And so I'd be happy to talk to anybody about those. In conclusion, NAFLD and MAFLD are common and driven primarily by traditional risk factors, but also by some unique risk factors that may be more important in people with lean NAFLD. Right now, what we can do is we can optimize modifiable risk factors and wait for data to see what our options are for pharmacologic therapies. So thank you.
Well, that was a fantastic overview, a very complicated area, and I can tell you already there are questions coming in, particularly online, on GLP-1 agonism, so that will come up in the discussion. I'll also note that probably for the first time in OPMAN history, we've had 2 people named Jordan speaking. I think that's a remarkable thing, notable. But we'll have Jordan come join us again, that is Jordan Lake come join us again for the questions, and we can dig into a little bit more to GLP-1 agonism. But I'm really thrilled now. I mentioned a couple times we rejiggered the agenda for today because of some challenges with air travel. But we're really thrilled that Devika Bhattacharya has come further and put in the greatest effort of any of our faculty to be here today to share with us a discussion on management of hepatitis B in people with HIV. And she really is the best person to give us this talk. She is leading the ACTG clinical trial group, the HepTSG. So she's leading clinical trials in this space. So we're just really thrilled that she's here, and welcome her to the stage.
All right. Thank you, Mark, for a wonderful introduction. And thank you to the organizers for inviting me to speak today. And most importantly, thank you for putting up with my planes, trains, and automobiles adventure to get here with canceled flights. So very, very excited to talk to you today about management considerations for hepatitis B co-infection in persons living with HIV. I think a really important and timely topic. These are my disclosures. So I have a couple of objectives. So I'm going to start with hepatitis B vaccination and considerations in persons living with HIV, because there's some really exciting data that's forthcoming that I think is really important to talk about. We'll talk about newer vaccines and then the management of the isolated anti-core serologic profile, which comes up, I think, more and more frequently. We'll also talk about management of hepatitis B infection in persons living with HIV, and we'll talk about this difference between tenofovir alafenamide and tenofovir disoproxil fumarate and some of the data that you might have been seeing recently about differences there. We'll talk about the consequences of incomplete HBV DNA suppression, and then also unintended consequences of treatment cessation. All right, so I always like to start with the why. Why should we care about this? So, a reminder that globally, 257 million individuals around the world live with chronic hepatitis B. 7.5% of persons with HIV also have hepatitis B co-infection. So that's about 2.7 million individuals. And a stark reminder that hepatocellular carcinoma, or HCC, is the 3rd most common cause of cancer mortality globally, with hepatitis B contributing 40% of liver cancers. And a reminder that when we think about the overall global prevalence of hepatitis B, that hepatitis B surface antigenemia is highest in the Western Pacific region. And many of us, of course, have patients who are coming from various different places. And a reminder that hepatitis B is high in prevalence in many of these areas. So why should we care about hepatitis B and HIV? Well, there's impact of HIV on hepatitis B disease progression. There are higher levels of hepatitis B replication when compared to those individuals without HIV. There's higher mortality when compared to HIV or hepatitis B monoinfection in persons living with HIV and Hep B. Individuals with HIV are more likely to develop chronic hepatitis B when exposed to hepatitis B, and that risk increases, as you can imagine, with a lower CD4 at the time of HBV acquisition. Kind of almost in contradistinction, they tend to have lower ALT levels, but that can belie more severe liver fibrosis. They have faster progression to cirrhosis, and they have a higher incidence of lamivudine resistance. Now, we don't use lamivudine anymore as single agent therapy for hepatitis B in HIV, in persons living with HIV, but it's important to remember that years ago we did. And so you may have patients who may have been exposed to lamivudine monotherapy, so a higher incidence of lamivudine resistance. So let's go to case one. So this is a person living with HIV who's naive to hepatitis B vaccination. And I went back and forth, should I make an ARS, should I not make an ARS? Because I'm not sure that we actually know the right answer, and we've got some really exciting data. So let's go through it. So this is a 21-year-old gentleman newly diagnosed with HIV infection. In terms of his hepatitis B markers, his surface antigen is negative. His hepatitis B core antibody, that's the anti-HBC, is also negative. And his hepatitis B surface antibody, or the anti-HBs, is also negative. Relevant to his HIV, his CD4 is high, it's 525, and his HCV is negative. So let's start with interpretation of hepatitis B serologic results. I sometimes think that this is kind of one of the best ways to start because it can sometimes be confusing. So when we evaluate hepatitis B, we evaluate 3 serologies to begin with. Hepatitis B surface antigen, the antibody to hepatitis B core, and then the antibody, the hepatitis B surface antibody. So we're going to call them here hepatitis B surface antigen, the total anti-core, and the anti-HBs. And when all of those are negative, that's someone who has never seen hepatitis B and is naive. That person needs to be immunized for hepatitis B. If you have somebody who is surface antigen negative, but core positive and surface antibody positive, that person has kind of immunologic control. So they are immune because they have been exposed to hepatitis B, but have had the robust immune response and have been able to clear hepatitis B surface antigen. In individuals who are surface antigen negative and core antibody negative, but surface antibody negative, or surface antibody positive, sorry, these individuals are immune due to hepatitis B vaccination. Those individuals who are surface antigen positive, core antibody positive, but surface antibody negative, that should be a red flag, right? That's somebody with chronic hepatitis B surface, chronic hepatitis B infection. And then we have the isolated core serologic profile, which we'll talk about more in depth. But these are individuals who are surface antigen negative, core positive, but surface antibody negative. And there are a number of different scenarios that this could represent, but really the most common is probably somebody with resolved infection. And so that means they were exposed to hepatitis B, they've got the core, but their antibody levels have been waning with time. And they actually represent, as kind of makes sense, probably the highest risk of things like reactivation and also non-response to booster doses of vaccination. All right. So now you have somebody who is naive to hepatitis B vaccination, and you need to decide about how you're going to vaccinate them. So why is this even an issue? Well, as it turns out, with standard hepatitis B vaccination series, including vaccine series like Engerix, the primary vaccine efficacy in persons living with HIV is reduced. So anywhere from just under 20% to 70% overall hepatitis B surface antibody response rates above the titer that we need, greater than 10, in individuals with persons living with HIV. And that's compared to much higher rates in some studies of 96% in persons living without HIV. So clearly, this is an area that needs, that needs work. And what the DHHS guidelines recommend in this setting is that when you're going to be vaccinating with standard, again, Engerix vaccine series, that you would use the double dose vaccine for the standard 3-dose series. But we have some exciting new data. So there are a few other kind of new kids on the block for vaccines, and one is called Heplisav-B, and this was already FDA approved. This is another adjuvanted vaccine which uses a synthetic oligonucleotide with cytosine and guanine that essentially is a TLR9 agonist. And it then boosts both T cell and B cell immunity to hepatitis B. And this has already been studied, obviously, in persons without HIV with very high overall seroprotection rates, ranging anywhere from 81 to, in some studies, 95%. So very exciting. And until recently, we didn't have data in persons living with HIV, but we now do. And so these were some very exciting results that were presented recently. ACTG 5379, or fondly called the Beehive study, which actually has two arms. It has a non-responder arm and has a vaccine-naive arm. This is the vaccine-naive arm, Group B, and these are individuals living with HIV who are being vaccinated for hepatitis B. Now, the standard Heplisav dosing, the FDA-approved dosing, is actually 2 doses. So that's at day 0 and then 1 month later. But for this study in persons living with HIV, because of the concern for efficacy, given previous studies with diminished efficacy with other vaccines, they actually looked at 3 doses. So 0, 1 month, and then 6 months. And individuals were enrolled, were excluded if they obviously had prior hepatitis B immunization and any immunocompromising conditions. And I think, importantly, their CD4 was greater than 100 at enrollment. And so here are the results. And I want to kind of draw your attention to a couple of things. One, remember, we have dosing at entry, week 4 and week 24. And then we measured seroprotective responses at various time points, but including week 8, so that would be 4 weeks after the second dose, and then also week 28, which was 4 weeks after the week 24 dose. And I think the thing that I really want to draw your attention to is, one, even after 2 doses, the proportion of individuals with the appropriate seroprotective response was 87% in week 8. And then when you looked at week 24, that went up to almost 99%. And I think most excitingly, when you looked at 4 weeks after the 3rd dose, that response rate was 100%. I think the other thing that I want to draw your attention to is that you can see that this graphic is in various colors. And the deeper blue are those individuals who had surface antibody titers of greater than 1,000. Those are really high titers. And we hope that they predict for a longer duration of response. And as you can see here, when you get out to week 28, 84% of individuals in this study had titers of greater than 1,000. That's really remarkable, and certainly something that we're all keeping our eye on. So I think the question there is, in this setting, is Heplisab going to be the new recommendation? And I think we'll have to wait and see, but I think it's very promising, and at least in my practice, has emerged as my first choice in persons living with HIV. All right, so now let's go to the second case. So this is the isolated anticorps serologic profile. So this is somebody who has HIV. Their CD4 count is high, 450. Their viral load is undetectable. They're already receiving therapy with bictegravir, tenofovir, alafenamide, and emtricitabine. And their hepatitis B serologies are the isolated anticorps. So remember, that's core positive, but they don't have their surface antigen and they don't have their surface antibody. So these individuals then have some kind of immunologic memory that we can see with the core antibody, but they are non-immune. So here's the first question. Let's vote. So what should you do with regards to Hep B vaccination? Do you start the Hep B vaccination series? You do nothing. Persons living with HIV with the isolated anticorps pattern do not need to be vaccinated for hepatitis B. They already were exposed to it and are probably immune. You give 1 dose of recombinant HBV vaccine and assess for the surface antibody response and then follow with a complete series. Or do you check HBV DNA, if positive, add a second HBV antiviral and initiate hepatitis B vaccination? All right. So what do we have? Okay, good. So we've got kind of a spread of choices, which is always good. So the correct answer here, based on what the guidelines are to give 1 dose of recombinant HBV vaccine, assess for the anti-HBs response, and then follow with a complete series. But I will tell you that my choice would actually probably also be to start the HBV vaccination series, but let's talk about that. So why is this important? So persons with the isolated anticorps syndrome, they do not mount a response to the hepatitis B vaccine when given as 1 dose. So this was a landmark study that was published now several years ago by Raj Gandhi and colleagues. And what he demonstrated is in those persons living with HIV with the anticorps, with this isolated anticorps serologic profile, only 21% had a response that was between 1 to 9 of titers of surface antibody, and the others had slightly higher antibody titers overall, but really overall a low response to the booster dose for hepatitis B vaccine, suggesting that these individuals are at risk for potential hepatitis B infection if exposed. And this has been duplicated in several studies following. And so the recommendations for the DHHS OI guidelines are to give then 1 standard dose of hepatitis B vaccine, assess the anti-HBs response 1 to 2 months post-dose, and then if the titer is greater than 100 million IUs per ml, no further vaccination is necessary. But if the titer is less than 100, then you should complete the series, and that should be followed with anti-HBs testing. And the rationale is based on a study that demonstrated that in individuals with this profile, that 100% of those who achieved a titer of greater than 100 milliIUs per ml after the booster dose maintained their anti-HBs response for more than 18 months, as compared to just 23% of those who achieved a titer of 10 to 100. Now, I will say that I think that there are some challenges, and I think that some of you may have picked up on that to this approach. And of course, this is the approach that's endorsed in the guidance, but you can also consider other approaches, and understanding that it's sometimes difficult to kind of bring folks back for multiple visits. It is not at all incorrect, I would say, to just go ahead and initiate the full series. So you guys also picked up on that. And then I think, the question now is too, where does Heplisab fit into this? And I think, again, we'll have to see. We don't have data to demonstrate this, but if you can imagine the peak of those titers and the hopeful a longer duration of the anti-HBs response, this may be a role for that and other similarly highly adjuvanted vaccines. Okay, so now let's move to case 3. So this is a new diagnosis of hepatitis B in someone living with HIV. So 63-year-old woman, newly diagnosed with HIV. She has mild renal insufficiency. She is surface antigen positive. She is E antigen positive, which denotes high replication. And her HBV DNA is 9 million IUs per ml, which is actually for hepatitis B. It's kind of pretty standard for as a viral load. And her CD4 count is 195. Her HCV status, she's also negative. And by transient elastography, she fortunately does not have advanced fibrosis. So now let's vote. What ARV regimen would you choose? Would you pick dolutegravir, emtricitabine, tenofovir disoproxil fumarate? Would you pick bictegravir, emtricitabine, tenofovir alafenamide? Would you pick cabotegravir, rilpivirine? Or would you pick dolutegravir, abacavir, lamivudine? All right, excellent. So you all picked the regimen that I would have picked. And so that is the bictegravir, tenofovir alafenamide, and FTC. And I think many of you kind of picked it, I would imagine, because of the renal insufficiency, right? So individuals with creatinine clearance of 30 to 59 should really be prioritized for tenofovir alafenamide because of the concerns of renal issues with tenofovir disoproxil fumarate. But I want to present some more exciting data, and this is evaluating the difference between a tenofovir alafenamide containing regimen versus a tenofovir disoproxil fumarate regimen. So this is a really very interesting study called the Alliance study, a randomized placebo-controlled phase 3 study. Enrolling persons living with HIV and hepatitis B co-infection and randomizing them to either bictegravir, emtricitabine, tenofovir alafenamide, or dolutegravir, FTC, and tenofovir disoproxil fumarate. It's a global study, participants from 11 countries, including in Asia, Europe, North and Latin America, and approximately 30% of those enrolled have high HIV viral loads. And the median HBV DNA here is 8.1 log IUs per ml, and 78% are E antigen positive. And recently, we have had presented 48-week results of this study. And the things that we see here that are particularly interesting are that when you look at HBV DNA suppression of less than 29, you can see that those on the tenofovir alafenamide containing regimen, a higher proportion, so 63% compared to 43% achieved HBV virologic suppression. When you also look at surface antigen loss, it's 13% compared to 6% with TDF versus TAF. And when you look at E antigen loss, that is also higher, 26% versus 14%. And that also translates to ALT normalization, 73% versus 55%. So really exciting data. Looking at tenofovir alafenamide versus TDF in persons living with HIV and hepatitis B. So does this mean it's superior? I don't know yet. I think there are a lot of unknowns. So we don't know what the quantitative hepatitis B surface antigen levels were at baseline, which we know is a predictor for overall response. And we also don't know what the week 96 results are. Is this an early result that we will see tempered over time? But I think many of us are very excited about it. And the reason that this may indeed have the effect that it has is, as you know, with tenofovir alafenamide, the active metabolite actually gets higher levels in the liver. And so the hypothesis is this is what's contributing to this accelerated, to these improved outcomes. All right, so now I want to talk about incomplete HBV suppression. So it's a good reminder that in persons living with HIV, having incomplete HBV suppression, particularly at 1 and 2 years, is not uncommon. So this was a retrospective cohort study in the US of 133 individuals living with HIV and hepatitis B. And they initiated tenofovir-based antiretroviral therapy And when you looked at 1 year, 54% had incomplete HBV DNA suppression. And that incomplete suppression was associated most strongly with an elevated HBV DNA level, which is not surprising, right? It takes some time to come down. But I think it's important to remember that it can take time to come down. And actually, when you look at 2-year data in the Swiss HIV cohort study, 27% of individuals at 2 years were still also unsuppressed. But this lack of suppression, not just at 2 years, but also at 4 years, 5 years, actually has implications. So this was a landmark study that was done by Nina Kim and colleagues using the NA Accord cohort, which is a large cohort of persons living with HIV, and they focused on individuals with HIV and Hep B. And what they looked at was the incident hepatocellular carcinoma over time. And they looked at kind of various stratifications, including what degree of viremia, both HIV and hepatitis B, that individuals had. And I think what was most interesting is that those individuals with undetectable HIV, right? So people that you think are taking their medications appropriately, who are taking their medications appropriately, have HIV suppression, but have detectable HBV viremia, those individuals have a higher rate of incident HCC compared to those individuals who are undetectable for both HIV and hepatitis B. And I think it really makes us think about whether or not we should be thinking about strategies to really drive down overall HBV DNA suppression, particularly in persons living with HIV and hepatitis B. All right, so let's vote. So the patient is excited for a potential injectable HIV regimen. What should you tell her? She can discontinue HBV antiviral therapy without any concerns. She can initiate long-acting injectable therapy, but needs to continue HBV antiviral therapy. She can discontinue HBV antiviral therapy with careful monitoring of HBV viral loads and transaminases. All right, so you all got it. She can initiate long-acting injectable therapy, but she needs to continue her HBV antiviral therapy. And so why is that the case? So there have been cases in persons living with HIV and hepatitis B of hepatitis B flares and hepatic decompensation when hepatitis B active antiretroviral therapy is discontinued kind of inadvertently. And I want to also talk about the hepatitis B monoinfection literature, where in persons who are e antigen negative, so in some settings, individuals may consider stopping therapy, that there are consequences. And so the first thing I want to point you to are the hepatitis flares that occur, so anywhere from 53 to 61%. And in the largest observational study called RETRACT-B, hepatic decompensation did occur at 1%. And so it's just a sober reminder, I think, particularly in our persons living with HIV, that we really need to be mindful about not discontinuing their HBV antiviral therapy that's part of their antiretroviral therapy. Now, interestingly, the flip side of this is that, at least in hepatitis B monoinfection, we are seeing some accelerated rates of surface antigen loss at that time of discontinuation. And that's a big discussion now in the hepatitis B world, is should that be used as a strategy? Certainly in HIV, we're not there yet. All right, and so the last slide I want to leave you with is that this is really an exciting time for hepatitis B novel drug development. For years, we had almost nothing in terms of novel drugs, and then from 2016 to on, we probably have about 40 compounds that are in development. And so many of these, really should be studied in persons living with HIV. Very interestingly, persons living with HIV actually have an accelerated rate of surface antigen loss, and this may be the exact population to evaluate these novel therapeutics in. So in summary, Heplisav, which is an adjuvanted hepatitis B vaccine, shows promise in persons living with HIV. Tenofovir alafenamide versus TDF, HIV and Hep B, certainly higher rates of surface antigen loss and e antigen loss, but it's too soon to tell which is superior. Incomplete HBV DNA suppression is common in persons living with HIV and Hep B. HPV-active antiretroviral therapies is not, cessation is not recommended in HIV and Hep B, and novel therapeutics for Hep B are on the horizon. So thank you, and look forward to talking to you in the other sessions.
Well, fantastic. You missed the earlier conversation this morning, but we did actually, you touched on and clarified a lot of the points that we talked about with respect to the isolated cores. So thank you for that. Well, great. We do have time for questions. There are some coming online, so let me start with those. Keep with the Hep B theme. One of the questions was, should you check titers after vaccinating someone? And what about someone who's vaccinated a long time ago? So you finish the series, should you check titers? Or you have a patient who may have been vaccinated a long time ago, should you check titers? So Debica, you get that question.
Yeah, I mean, it's a great question. So if you look at the guidance, there is not a formal recommendation, but there is kind of a suggestion, or some experts may actually check surface antibody titers annually to look to see for decline, because we know that even in persons without HIV, that antibody titers wane over time, and that actually is accelerated in those living with HIV. So if you look out 7 years, only a small proportion of individuals have anti-HBs titers of greater than 10, which is the threshold that we think of. I think the big question is, but what does that mean? You have memory. If you were to be re-challenged, would you be able to mount the same response? We don't know the answer. So I think the short answer is, I think there's nothing wrong in checking it annually, and it's something that I do in my patients.
So you do that in people with HIV. What about people without HIV? You struggle with this a little bit. And I guess where it comes up in my practice, I have patients with active Hep B and their family members, whether it be a partner or children in the home, and whether or not we should try to maintain their titers at a level above 10 or some other level. And that question comes up quite a bit in terms of monitoring people who with exposures.
Yeah, I think that's a great question. Again, when you look at the Alaska Native cohort study, again, over, several years, there is a loss, but a substantial proportion maintain their anti-HBs levels. I think it's on a case-by-case basis. I think it's somebody who's at very high risk, like a family member with hepatitis B. There's certainly no harm in checking and potentially boosting if you needed to.
Yeah, I think that's an important point. The vaccination is safe, despite alleged controversy. So let me go to the microphone in the back there, here in person.
Thanks. I was just wondering, you said that now you are preferring Heplisav-B for your patients living with HIV. Are you always doing the third dose? And how are you checking those titers?
Yeah, I mean, again, excellent questions. Prior to this data coming out, prior to the 5379 data, I was only doing 2 doses, right? Because that's what we had. And now with this, I think there is an argument for doing 3 doses. I haven't had that patient scenario come up yet, but I think that it's a perfectly appropriate approach. And I think in terms of, assessing response after that, you would do it 1 to 2 months after the 3rd dose. And then I think it goes to are you checking levels annually? Again, in the guidance, we say that you can consider it. And so I think that's certainly something that we could do.
I'll just comment that the cost effectiveness of the 2-shot vaccine is in part predicated on its 2 shots 1 month apart, so greater completion rate and greater response rate. So it'll be interesting when the rest of the Beehive study is done to get those answers, the one that's vaccinating non-responders. That's it. It's a great question. We'll go to the microphone in the center, then we'll go back online. That's you. Yeah.
Yes, so I don't know what your experience has been or others, but I've found that sometimes or often that third-party payers don't want to pay for Heplisav-B, and that they'll pay for Energix, and our hands are kind of tied in that regard. But have you had any issues with that?
I just want to repeat, so third-party payers are not,
are pushing back on paying for Heplisab B, but they will pay for Energex. So
yeah, I mean, I have not had that in my experience. I'm dismayed to hear that, but hopefully, you know, once the data is published, I anticipate that we'll see what it does to the guidelines, and that may impact.
But I do have, speaking of guidelines, I do have another question, and that is, can you explain to me the rationale why the guidelines say that if you're co-infected with Hep B, that you should be using 2 drugs? Now, in all honesty, we're going to be using BF-TAF, or usually it's you know, F-TAF or FTDF that's in combination. But why is it with co-infection but not mono-infection? Do you believe that 2 drugs are the way to go? Do you really believe that the FTC or 3TC, you know, compared to entecavir or tenofovir, which is a whole order of magnitude or more higher in virologic suppression, that it's actually contributing to the antiviral, you know, effect in co-infection but not mono-infection?
Yeah, that's another great question. You know, the guidance for dual active HBV therapy was really kind of based on the data when lamivudine was used alone right before tenofovir. And when you looked at lamivudine resistance in persons living with HIV and Hep B, it was 90% at 4 years in some studies. And so I think to prevent that, to make sure that we were understanding that you really need to use another drug plus lamivudine or FTC, came the recommendation to combine that with tenofovir, either TDF or TAF. Your point is well taken, though, which is TDF, you know, that was when we were trying to steer people away from just 3TC when that was available. But if you could just use TDF in a regimen, right, would that be good enough? We don't have data, and nor do we have kind of the ART regimens, right, that would allow for that, with the exception of potentially now long-acting injectables that are coming out where that might be an option. But that was the history behind that for dual active.
So I do want to share, Mark, that I had an extensive conversation with Rich Colonna back in 25 years ago or so at BMS when they were developing entecavir, and he thought it absolutely made no sense to add 2 drugs, lamivudine to entecavir, because of that very reason. So I just was curious as to how it made it into the guidelines.
Yeah, well, I'll comment that with adding lamivudine to entecavir, the logic there is a little bit less because they're both L-nucleosides. There is some more logic to adding entecavir plus tenofovir, but you're right about the clinical data being relatively sparse, that patients treated with dual polymerase inhibitors have better outcomes from a Hep B perspective, but that's a really good point. So I want to shift gears and go back online. We've got some questions about, for Jordan, for you. One question is, do you routinely measure insulin sensitivity? And if so, how do you do that in the care of people with HIV?
Is it just on? Okay. Well, I'm biased, but I tend to measure insulin sensitivity quite a bit, and because I just want to know. And the 2 easiest ways, I would say, you can check an insulin level, a fasting insulin level, through most of the clinical labs and calculate a HOMA-IR value. There's online calculators available. And anything above 2 would be considered insulin resistance. The caveat to that is that clinical lab results for insulin vary quite a bit. And so how accurate they are is not, you know, you won't know necessarily, but certainly if you did it over time and it was always over 2, then you could feel confident. And then there's the triglyceride to HDL ratio, which has been proposed as an easy measure of insulin sensitivity that you can get because you're checking lipid panels anyway, and that should also be higher than 2. And so that's just a quick check that you could do to look for insulin resistance in clinic.
So somewhat related to that, there's been an increasing push from patients kind of mixing in Dr. Treisman's talk with with your practice. How are you handling patients who want to take GLP-1 agonist in practice? People who may, depending on what they're asking for. How are you handling that in your practice, and how do you think we should be responding to these requests?
Yes, I personally haven't had to face that much because I work in a county healthcare system where they're just really not of access to most of our patients. The ones that do have insurance, the easiest thing for me to get is liraglutide, but I've even had, when people meet criteria, had insurances, particularly Medicare, deny that. So this patient pressure that you hear about where, there's a semaglutide higher dose shortage because people are wanting to manage their weight with it, whether or not they meet criteria for that. I hear that it's happening, certainly. I haven't. I think you have to push back. Someone should not be taking that drug for cosmetic reasons. It has a lot of potential side effects. Some people just tolerate it very poorly. There are also non-responders, and if you're a non-responder, you've wasted a lot of money to try and lose weight with that drug. So, that's not what it's for, and we should do the right thing for the patient. And as Dr. Treisman said, so for me, I would not bow to that pressure if the person didn't otherwise meet criteria. But we will have a lot of people that cannot do lifestyle intervention for a variety of reasons. And, just going straight to those drugs, if you think your patient fits that criteria, even if they don't meet insurance criteria, that may be somebody that you want to push for and argue with.
That makes sense. Thank you for that. And I want to keep with the semaglutide sort of theme. I know you worked very hard to get the slim liver study you referred to up and running, and it's remarkable to think of the data actually coming out this summer, I think you said, but I may have missed it. I know you talked about the 1 milligram dose versus dose being used. Are there plans to do a follow-on study looking at the higher doses in people with HIV?
As of now, there's nothing on clinicaltrials.gov, so I don't know if anyone is planning that. I think one issue that we will see out of these lower dose studies is tolerability different, and that's something that's very important to see. Tolerability may very well be different, and we would want to think, differently about designing a study if we think there are going to be more tolerability issues in our patients. But I think with slim liver particularly, because it's the one designed to measure hepatic fat by MRI, if you see a signal, and certainly there's a weight loss signal, I would anticipate that there should be a hepatic fat signal, but we don't know till we see the data. If we see a signal, I think that is the next step, is to see, well, what kind of benefit can you get from the true weight loss? Because slim liver was designed as a pharmacologic weight loss study. And so, people who may not get the same benefit out of 1 milligram as they would get out of 3.4 milligrams.
Oh, great. Well, thank you for that. We'll switch back to Hep B. And a question, Debica, I'll send to you is talking about this intersection of PrEP for HIV. And how do you, the question was specifically, does it protect against the acquisition of Hep B in someone who's non-immune? And two, just talk a little bit about that intersection of TAF, FTC for HIV and Hep B.
Yeah, I think there are two kind of questions there, right? One is in individuals who are receiving PrEP, that obviously have HBV active agents, right, tenofovir or TAF, what is the protective effect? And actually, there have been several now observational studies that demonstrate that there is a reduced risk of acquisition of hepatitis B, anywhere from 50 to 90%, depending on the study. But what I would say is that doesn't mean that individuals who are receiving PrEP should not get vaccinated. And I think that is kind of the big take-home question is you got to make sure that your patients are screened for hepatitis B and if they're non-immune to vaccinate. Because even though there does seem to be a protective effect against acquisition, people stop taking their PrEP. They don't take their PrEP, consistently sometimes. And so we don't want to run that risk. And I think kind of a telling tale is recently reported from the FLAIR study, right? That was cabotegravir and rilpivirine. And they had one person who was actually immunized against hepatitis B, but found out they just did not mount an appropriate seroprotective response, that they actually developed acute hepatitis B while on cabotegravir and rilpivirine, but it was because they were essentially non-immune. So the key point there is make sure that individuals are screened and vaccinated if they are non-immune. And then I think the other point is about, can individuals with chronic Hep B initiate PrEP? And I think that is a really interesting question. So right now, the PrEP guidelines say that that is not a contraindication, but you have to make sure of a couple of things, right? The first thing you got to make sure is that they do not have cirrhosis. Because if they have advanced liver disease or cirrhosis, those individuals need treatment for their hepatitis B, and PrEP should not be stopped. The PrEP with tenofovir should not be stopped, and those individuals should be managed by somebody who manages hepatitis B. But in those individuals, now you're assessing patients for fibrosis, you're assessing their ALT and AST prior to starting PrEP. In those individuals who are surface antigen positive, who do not have evidence of advanced liver disease, so normal ALT, we have seen in studies that those individuals can safely take PrEP, and even on discontinuation, at least in a small subset of patients, they have HBV viremia flares, but they don't, and mild ALT elevations, but they don't have hepatic decompensation. I think that's a fine line to walk, and I think, we're going to see that Hep B guidelines are going to be moving, I hope, to maybe more overall treatment. And so maybe we don't have to ask that question about discontinuing therapy in PrEP for somebody with surface antigen. But those are the two key issues: vaccination if non-immune, and then if they're surface antigen positive on PrEP, it's not a contraindication, but you have to assess for fibrosis for their liver disease status.
Yeah, it's a really good point. And I think for our audience, it's important to remember, Jordan Fell today talked about the stop nuke and talked about the 4 outcomes you can have, some of them good, some of them bad, some of them really bad. And in a sense, if you're stopping PrEP in a person with active Hep B, you're doing a stop nuke experiment. I'm not saying so I just think it's something that you should be well thought out as
Correct.
you step into it. Well, I think what we'll do, it's about 12:15 here on the East Coast of the United States. We are going to take our break, and then we're going to circle back here at 12:35 for our working lunch and case presentation. So lunch will be ready outside. Go grab some lunch. Those of you at home, well, you've been taking breaks all morning. Let's be serious. But, I think that go ahead and take a break for lunch and come on back at 12:35. And we'll gather for case presentations. I want to thank both Jordan Lake and Debica for their wonderful presentations today. And welcome everyone back. I wanted to give our faculty a chance to finish chewing before inviting them up to the panel here to do some cases. So we'll spend a little bit of time, ask our panelists to assemble here, and we'll go through some case presentations, and we've got plenty of time to walk through these. So, happy to take questions and more conversations. For those of you at home, we're going to do case presentations until about 20 minutes after, and then we will be breaking here in Orlando for roundtables. But we've got a critical mass of folks up here, so let's go ahead and talk through some cases. We'll have some audience response and try to amplify, if you will, some of the discussion points from earlier today. So let's go ahead. We'll start with the first case. This is a 41-year-old man with chronic hepatitis B, diagnosed about 15 years ago with a ALT of 21, a viral load of about 5,000. He's had viral lows measured over the years, but no treatment, and he wants to start treatment. So he's got a history of alcohol use disorder with multiple hospital admissions, but he is engaged in Alcoholics Anonymous as well as taking naltrexone injections monthly in the clinic. He had a recent relapse in drinking requiring hospitalization. And in the EMR, a documentation of a recent chlamydia test that was positive and treated a couple of months ago. So let's go ahead and vote. I think we've got this down by now. It's the last voting session of OPMAN. So which of the tests is not routinely recommended by the AASLD guidelines as part of his workup? And the choices are HBV DNA, anti-HIV, Hep B surface antigen quant, hepatic function panel, or anti-HDV testing. So which one is not routinely recommended as part of the workup? Well, that's an interesting response. So let me start with Ken. You touched on this one. What will you pick on that list of things not to order in this guy's routine workup? Not your academic workup, your routine workup.
Routine workup. I mean, I would not get quantitative surface in that patient.
But anti-HDV, you'd get that?
HDV?
So the leader, now maybe this was it's a negative question. Sometimes those get people sort of thrown off, but about 64% said no Delta antibody testing.
Yeah.
Let me ask for a show of hands. How many of our panelists would want a Delta antibody test on this guy? Now, hopefully we can see this image. Delta antibody, yes. Glenn, you can have one.
Do we already know he's positive? So then I would want one.
So the answer here that's intended was the Quant S, and that's not routinely something we're doing in practice. But I did want to highlight, and Ken made this point, but I wanted to come back to it on the next slide. The next slide, there it is. That the recommendations right now are not for universal screening. Over to the left, you have EASL recommending universal screening, meaning you've got Hep B, you test for D. But this guy is someone who would meet the at-risk criteria, and I bolded the reason why, because he has a history of a sexually transmitted infection, which places him at risk. And hepatitis delta is a sexually transmitted pathogen as well. In fact, there are some really large outbreaks globally. So he would have been recommended to be tested. A complicated guidelines. We hope we'll get to the point where it's more simplified. Yeah. So let me jump ahead. So this is the rest of his workup. His ALT is 40. There's a reference range at the lab going up to 65. We can touch on that point. I did do a hepatitis B surface antigen test because, well, as I mentioned earlier, I can. After a 2-year battle of getting that into our EMR, I can now order it, which has, and I think the information, but he's got a very low Hep B DNA. This is not on treatment. He's negative for other pathogens. So debatable whether he meets criteria for treatment, given his HBV DNA is so low. Jordan, you talked about Hep B today. Do you anticipate any guidelines? So you talked about the guidelines coming from China that say any DNA. So 73 is pretty low.
Yeah, and actually that's one of the points that's been raised in people reading carefully through those guidelines is even the Chinese guidelines are a bit vague on which DNA test is used. So it depends on the sensitivity of the test you use will depend on whether it's positive or not. Some HBV DNA tests would call this 73 negative. I think it's unlikely that the American guidelines will go to something to recommend treatment in anyone who's DNA positive at this threshold.
Great. And I guess another question for our panel, is that a normal ALT?
That is not a normal ALT, say the liver doctors.
No, it is not.
So Ken, why does the lab give me a reference range that goes up to 65?
Because they're using a statistical measure rather than a disease-based measure of determining upper limit of normal or lower limit of normal. Right?
Yeah, no, it's a point just to drive home that the lab is not telling you it's normal. They're telling you what the reference range is, and that will change at different labs, and this lab happens to have a pretty high one. Well, let's go ahead and vote. So we've got the data. You've heard some feedback on it. So what would you recommend? 1 is to monitor but no antiviral treatment. 2 is entecavir. 3 is tenofovir. 4 is tenofovir emtricitabine. And 5 is a cabotegravir extended release injectable suspension. So what would you recommend for this individual? So 40% want to monitor with no antiviral treatment, but a good 42, and the winner would be tenofovir emtricitabine. Devika, what would you do?
Yeah, I mean, great question. So if you look at the AASLD guidance, so I just want to recap this scenario. So he is hepatitis B surface antigen positive, E antigen negative, and very low viral load, right? 73. So, and ALT of 40, which is slightly elevated. So if you look at the guidance, right, we divide it by E antigen positive disease and E antigen negative disease. In E antigen negative disease, the threshold for starting therapy after looking at E antigen positive and E antigen negative, you're looking at ALT, you're looking at HBV DNA, and of course anybody with cirrhosis would deserve to be treated. But in that scenario, in somebody who's E antigen negative with a viral load of less than 2,000, which he has, he currently would, and it's mildly elevated ALT, he currently would not meet criteria for treatment. So I don't think it's wrong to monitor him off. I mean, I think there is this discussion about, you know, should we be loosening that criteria? And I think that I would approach it from a case by case perspective. I think in him, the thing that concerns me is potentially, you didn't tell us about adherence, but whether or not there might be adherence issues. And that might sway me in the sense that if you have a sense that he's going to be non-adherent for various reasons, I might hold off on starting.
So it looks like our audience and our voting audience thinks that Hep B treatment itself may not be necessary. But Susanna, I saw you waving your hand down there.
I was feeling very lonely. Well, I would make one comment. So I thought it was interesting that he had a higher viral load with a normal liver transaminases, and then his liver transaminases become abnormal, in my opinion, and his viral load goes down. I noticed he had an STI, and I noticed that you checked a Hep C antibody and not an RNA. And I would say that something's a little off here and where his liver enzymes are, and I would query whether or not he has another viral infection of his liver. And I would want that before I made any decisions about treatment.
Well, I think the alcohol use disorder is thought to be affecting his liver intermittently. I think part of the reason why I posed this was the question about whether he might not be a candidate for HIV prevention and using tenofovir emtricitabine for PrEP in this kind of discussion that Devika raised about, does he meet Hep B criteria for treatment? Maybe not. But does he meet criteria for PrEP? Maybe. He has one sexually acquired infection a couple months ago. And maybe worthy of a discussion about whether or not to treat him. Now, if you wanted to, or to provide him with potential PrEP. That was sort of where I was going with this case, although I think the points are really well taken. And I do struggle with the idea that I think it's the AASLD guidelines say that if the alcohol is making the ALT go up, that doesn't count in the Hep B guideline, which always is a bit of a head scratcher. And I don't know if, I don't know, Ken, what do you think about these concurrent things on top of Hep B, for example? How do you weigh that?
Yeah, I mean, these are causes of injury that are really hard to sort out, and especially without a liver biopsy as part of your evaluation. I mean, alcohol injury looks different than hepatitis injury, and a biopsy may be helpful if you're contemplating intervention.
If you thought that there's a comorbidity with alcohol and hepatitis B damaging the liver, would you be more eager to treat this guy to prevent hepatitis B damaging his liver when you know he's going to be exposed to alcohol?
I would be more likely to try to get him to stop his alcohol.
Yeah, but
first.
Yeah,
That's,
yeah, go ahead.
But that question does come up though in clinic, when we have individuals with hepatitis B alone who don't meet criteria, but they have like fatty liver disease. And we think that that's a contribution to kind of their stuttering ALTs. And in those situations, I mean, full disclosure, I think we should be starting treatment earlier in everyone, but particularly in those situations, I will actually advocate for therapy in the setting of kind of fatty liver disease and hepatitis B earlier than in patients who don't.
So I will say, and we'll move on, but in this patient, this is sort of based on a patient I cared for recently, eager to be treated for Hep B, even though we've talked about the parameters being low, potentially at risk for HIV acquisition and at risk for liver disease via alcohol. So we went ahead and actually gave him tenofovir tricytidine for treatment based on his desire to be treated. But I think this spread of sort of discussion really kind of highlights the case. I'm going to jump ahead. This is a case plus a question, so we'll be voting after I read this. A 46-year-old man presents to establish primary care. According to which of the CDC guidance, which of the following would you recommend for tests or procedures for him to have? And you see the list there: HIV testing, Hep C testing, Hep B testing, colonoscopy, or all of the above. These are CDC guidance for primary care. So 90%. And I really just wanted to highlight this point. I won't belabor it, but there is a recent recommendation from the Centers for Disease Control for this antibody testing for Hep B. So HIV testing of adults, Hep C testing of adults, colonoscopy, they moved down to 45. I know we have a couple people here with the skills to do endoscopy. We can come back to that. But I did want to ask one question. We talked a lot about hepatitis B core testing, which I find the source of a lot of confusion among, you could say medical students, but let's be honest, it's actually among people who are across the entire spectrum of healthcare. When you add the core test, it creates, as we saw today in the chat and in the discussion, a lot of questions. So I'm going to put somebody on the spot. Jordan, you're looking over at me, so it's you. Should we be testing for core routinely, which is now the guidance we practice under in the US?
Yeah, I think it's questionable. I mean, when they did the cost effectiveness analyses to do this, they were pretty vague about the role of core in this, and they did not account for extra referrals that come from core antibody positivity, which almost undoubtedly happen. So if you look at if you sort of dig into the details of the analysis that the CDC based this on, they just put in the cost of the test. But I do think it will lead to a lot of, I don't know if confusion maybe is too strong a word, but probably, unnecessary referrals. So unless there's really good education around this testing that comes, and also with the resulting. So if the test comes back with a result with really clear instructions, hopefully that will lead to mitigating the risk, I guess the risks associated with it. But I do think it's opening a bit of a kettle of fish.
And the argument was it would allow you to know if that person was at risk for a flare if they later got, when you watch those TV commercials that say, tell your doctor if you have B, presumably you would identify that person as someone at risk. But then it gets to the question, if they're getting prednisone for poison ivy, is that at risk of flare? So it creates a real lot of questions. Debica, you had your hand raised.
Oh, no, it was actually just exactly what you said, though, is that I think I understand the reasons behind that, and I may also have had issue with core, but the counterpoint is we are going to be picking up on patients who otherwise, we know sometimes screening is not ideal as patients receive immunosuppressive therapy, and at least you have something in the chart, of course, that requires being followed up on, and that's another story.
But yeah, I guess my counter to that would be that A, does that stay in the chart and accompany the patient when they're getting their immunosuppressive therapy? And B, even in the context of immunosuppressive therapy, one could argue that core antibody should be tested when they're getting therapy that has a risk of reactivation. But if they're getting like standard solid tumor chemotherapy, which has almost no risk of reactivation in that setting, it can sometimes delay their chemotherapy and lead to sort of negative consequences actually of screening for core as well. So I definitely think it's a questionable recommendation, and hopefully there will be good education that accompanies it.
And we had a lot of questions we dealt with today about should they be vaccinated, the isolated core anti-HBs negative people. So, I think part of it is as practitioners in the in this space of HIV and hepatitis, I think would be prepared for more questions. It's just routinely tested. In fact, I got asked one not too long ago of a person who was taking HIV PrEP with a Hep B active drug who was isolated core positive. And the question was, will this person flare if I stop? And we reassured them that they could stop, but it was something that hadn't been considered until these guidance came out and they did the testing. So I'm going to jump ahead. So this question actually came up. So this was a 48-year-old man admitted via the emergency department with a necrotizing infection of his left foot. He has an emergent amputation and gets IV antibiotics. He's got active opioid use disorder. He's on methadone as well as counseling. He's got a constantly hemoglobin of 8.2, active Hep C, previously evaluated, prescribed therapy, but never actually connected the patient with the pills. Genotype 1A, a fibrosis panel of stage 2 fibrosis. He's going to need 6 weeks of IV antibiotics due to residual osteomyelitis in his metatarsal bone. So, the question is, would you recommend treatment now? And you have several options. Yes, start as an outpatient after discharge. Yes, start as an inpatient now. 3, stabilize his infection, his diabetes, and his opiate use disorder first, or you can punt and say maybe. Oh boy. I want to recount. No. So Dr. Nagy did foreshadow this case, and I don't believe I shared it with her before, of this idea of treating people who are in the hospital. And one of my colleagues at Johns Hopkins, Steve Barry, looked at this recently. About 2,000 people come through the doors of Johns Hopkins Bayview Medical Center and Johns Hopkins Hospital with active hepatitis C. And they're oftentimes given an appointment to follow up on discharge, but really not treated. We then at one point had one of our nurses coming from clinic to go talk to people. And then we went back and looked at the number of people who showed up after this consultation occurred. It was 1 in 160 came to their appointment. So we decided that might not be an effective model. But let's hear Susanna, you really hammered this point home, including during the voting. So go ahead and expand on this, then we'll go down the line.
Yeah, no, I mean, I think the issues are logistics, right? But as I mentioned, we're actually starting, and this is easier for me. I practice at both Duke and the Durham VA. This has been easier for me to institute at the Durham VA. Because I don't have to, do any prior authorization or try to get drug in-house. But we are starting a rapid startup inpatient for very high-risk patients. So these are patients exactly like this one who have been seen. They've even been written a prescription, but they never showed up for that appointment that we asked them to come to that they didn't really need to come to. And so we're trying to get them in-house, their, anything they need, and then get them on drug. And I think, again, if we're going to get to the highest risk patients, the patients that are, again, part of the numbers that we see for increased incidence and are likely going to be the most difficult to get to for eradication or elimination, we're going to need to do something novel. And I think this is where it starts. You could look at this in the EDs. We know this for patients coming in who have endocarditis and complications from injecting. But frankly, the patients that we've started recently in this sort of, what we're doing as a pilot, have actually been patients who are coming in with an acute myocardial infarction, or they're coming in with other things that are unrelated to opioid use, but because of underlying psychiatric disease, because of challenges with stable housing. Those are some of the other things that we see. And so it's not just the IDU population. There's a lot of other things socially that drive this, and we're just trying to get to everyone. Again, we're calling it kind of high-risk patients, but.
So Glenn, let me ask you, the one about stabilizing his infection and his diabetes and opioid use, that's kind of the idea of getting him ready for Hep C treatment. How should we think about that? He wants treatment, by the way.
This is a great question. The question I would ask as a guy who's been doing this for a long time is, why wouldn't you? And the only reason why you wouldn't is because the hospital have to pay for it instead of somebody else. And I'm unsympathetic with the hospital, as they know. I mean, I think that our job is healthcare. It doesn't cost any more to treat this guy as a society if he's in the hospital. It costs more for the hospital specifically. So I couldn't think of a reason why you wouldn't start this guy. he'll be 6 weeks, he'll be most of the way through. And that's pretty good for a lot of our patients. So the one thing, is this one of these trank guys? Is this a xylazine guy?
No, well, actually, the tox screen didn't have that in there, but no, not that we know.
You guys know about xylazine, right? Does everybody know about xylazine?
Please.
Trank? Yeah, so I don't know if you have it here, but it's coming to a theater near you. This is an adulterant put into fentanyl that nobody can understand why people are putting it into fentanyl, because it's not very reinforcing, but it is very bad for the vasculature. It causes these horrible skin lesions and frequent amputations. So it's a bad drug.
That's really a great point. Well, I'm going to jump ahead and just go on here. So he does get, the hospitalist care for him agreed to order some laboratory tests for us. We have to check off a few boxes to get that done. We plan to start therapy, but as Glenn alluded to, the drugs are not on the hospital formulary. So we wrote a prescription for outpatient coverage, which of course require prior authorization.
Right, this is
So which of the following is associated with healthcare provider burnout? Curing Hep C, successfully treating HIV, successfully treating Hep B, or prior authorization requirements for HCV therapy? 93%. I personally enjoy curing Hep C. It gives me great pleasure. It kicks off that, is it dopamine 1 receptor, Glenn?
Yep.
Yeah.
I mean, I would like to use this data in my next lecture.
But I will say I do get some satisfaction about winning the prior authorization fight. But so who, well, let me go to the next slide and then we can talk about it. So this is the state of Hep C, which is a pretty cool website. 31 of 52 states plus Puerto Rico still require PA. Susanna, you talked about the national elimination plan. Will this be the end of prior auth for Hep C therapy?
Well, I mean, I think this is why we are going to have to make sure that we're engaged in these conversations with the group that's leading this in the White House, because we're not going to be able to get to what they're saying they want to do. Now, if they really do the subscription model, I think as someone mentioned, that should really lower the barrier here, because that is the federal government paying for those medications so that payers are not paying for them. I mean, these are going to be targeted largely, again, to high-risk groups and groups where there's still limitations, but hopefully that'll lower the barrier. But I think for those that we want to continue to get access through insurers, we're going to have to push on this.
Can I just add something, that there's a huge part of this needs to come from primary care. So it can't all come from academia where people are treating these, infections, because really, as Susanna clearly pointed out, for elimination to happen, it has to happen in primary care, and the lobbying for getting coverage and getting some of the PAs taken away has to come from primary care.
Yeah,
so can I make a comment about that? Because this gets to also the burnout issue. Primary care docs, we've tried to start resident clinics for treating Hep C, and some of the pushback we've gotten from faculty is, look at all the things that we treat, all the preventive things we do. We don't want to do this, and we're doing enough. We want to send this patient to you, and we want you to make it easy to receive that patient. So, you know, whether we agree with it or not, you know, we say there's not enough of us, both ID and hepatology, to do that. But the primary care in our region is not embracing this as a whole.
So Jordan, you had a comment. Go ahead.
Oh, I just had the comment that it looks a complicating factor is that Texas, for example, my home state, it looks nice that it says no prior authorization is needed, but if you don't have Medicaid expansion, it doesn't matter. So it's incredibly difficult still.
I wonder about that when I dropped this slide in. Texas looked a surprising, well, I'm going to stop there.
Yeah, I mean, I think both points are correct, right? We're not going to eliminate hepatitis C without primary care involvement, and primary care providers are incredibly overwhelmed and burnt out. And an alternative solution, though, is to find different systems. And so one system that we have used, so like Susanna, I also am at the VA as well as UCLA, and we have used advanced practice providers, or APPs, to manage hepatitis C. So NPs, PAs, and PharmDs actually run our hepatitis C program at our VA, and I think that's one thing to consider.
Yeah, I think pharmacists are a big part of elimination in the United States. We've seen the breadth and depth of that model, both with HIV care, but also with COVID in the recent years as well. So I'm going to move on. I'll tell you what happened with this individual. It took 4 weeks to get prior authorization. Actually came to his outpatient appointment and started therapy. So I was the most surprised person in the room when he showed up and they checked him in, but I was really thrilled because it took us 4 weeks. I wanted to start in the hospital. I was thwarted by the powers that be, Glenn.
There you go.
I gave IVIG to a patient on psychiatry 2 years ago, and they had a hearing to decide whether or not I could continue my practice. I won, but IVIG on psychiatry was not popular.
All right, so let me jump into another case. We'll try to get a few more squeezed in. 62-year-old retired clinician, long-standing co-infection, no prior antiretroviral therapy, treated with tenofovir for more than 15 years, a low liver elastography score. We've done multiple of them. More than a year ago, he became Hep B surface antigen negative, DNA not detected, but he's anti-HBs negative. He's had a functional cure, which Dr. Fell told us we're trying to achieve. We like this. But the question is, what would you recommend now? Should he continue tenofovir indefinitely? Continue until he seroconverts, perhaps with vaccine? 3, if he wants to, switch to a dolutegravir-lamivudine 2-drug combination, or if he wants to, switch to a cabotegravir-rilpivirine extended-release injectable. Well, interesting. So I guess the majority want him to continue tenofovir. Let me start. Ken, what would you do? Does he need to continue tenofovir?
Yeah, so there's 2 parts to this. One is the durability of the response, and data mostly from Asia suggests that if someone is going to flip back in a non-HIV infected, it almost always happens by 18 months or so. So you can argue that 1 year is not sufficient. In the setting of HIV, the issue, we were talking about this before in relation to vaccine response, but it's the same. Patients don't always stay on their meds. And so you're likely to have some percentage of people that become more immunosuppressed again and also would be likely to flip back. If there was a good titer anti-HBs, I would be much more comfortable, and I would have chosen continue until anti-HBs positive.
Any others? So, Debica, would you, you now have the TLR9 agonist vaccine that we talked about today, and you're heeding Ken's advice. He told you that the patient should be anti-HBs positive. Are you going to try to make him anti-HBs positive by vaccinating? Will it work, and would you do it? I don't have the answer. So
Oh, that's a great question. I don't know. I don't know the answer to that. I mean, I think, yeah, I suppose you could try. That is a strategy that I had not thought of before. I mean, I like Ken though. I actually might continue tenofovir indefinitely though. I'd agree with the rest of the group. Unless the patient wanted to switch for some reason, because I guess the question is, I mean, there are harms obviously to continuing tenofovir indefinitely, but with the risk-benefit ratio with hepatitis B, why not continue? Is my thought. And I don't really have an answer about vaccine.
Let me go to the at the end here. I saw some eager discussions
the
down there. They have something to weigh in at the end.
Look, I think this is something that we are working through, but I've actually had a couple of these patients. I was telling Jordan earlier that I've had a couple of these patients with HIV Hep B. We know that these patients can clear when going on antiretroviral therapy, potentially depending on what their CD4 count is at even higher rates. I don't think I would necessarily choose, I don't think I would say that this patient needs tenofovir indefinitely. I think that the point that Ken makes is a really good one, that when we think about Hep B mono-infected patients and patients who do go on to clear, the concept of kind of a maintenance phase before you withdraw therapy, if you will. But I would just say that this, to me, again, this gets back to it's important that we remember that this patient had Hep B infection. I think we know that when you have an isolated core, you're higher risk for reactivation. I don't know that I would not allow this patient, for example, to switch to an injectable, but this is a patient that I would monitor to make sure that they don't have evidence of reactivation in that setting. But I think if I've seen this a number of times, and I've seen this where patients never developed an antibody. I've got patients like this with HIV Hep B for years, and I know this question's coming. I would just want to make sure I remember this and monitor them if we do remove that tenofovir-based therapy.
I agree. So I want to ask formally the question about vaccination for this person. So let's go to vote real quick. Would you vaccinate? Dr. Sherman told us you'd like that person to be anti-HBs positive, and we all agree. We like it when it's positive. So about 80% said yes, and it's hard to know. I can see Jordan is looking a bit skeptical at me, for those of you who can't quite see, but we did actually literally have this conversation about whether to do it or not, and I think it's certainly a consideration. I'm going to ask one more question related to this individual, I believe, if I could have the next one. Would you continue? So this is a question that's an active one right now. Should he continue hepatocellular carcinoma surveillance? He's been getting ultrasounds every 6 months, or at least, if I'm perfectly honest, not really every 6 months. It's, we lose that track. It's hard to get to the ultrasonographer every 6 months, and we're constantly ordering them. They're done outside of our health system. So should we continue? No, yes, and maybe. So overwhelming is a yes or maybe. Well, Jordan, you've been doing a lot of nodding over there, so go ahead and give us your, Jordan Fell, that is.
Yeah, so when people lose surface antigen, the age at which they lose surface antigen is probably at least somewhat associated with the risk of cancer after. And studies, albeit with not huge numbers, suggest that if people clear surface antigen before age 50, their risk of cancer is quite low, whereas if they clear after age 50, they have a persistent risk. So this is he was over 50. Whether HIV contributes to that, not well studied, but may increase it a little bit. So I certainly, in this older man, I would continue surveillance.
Any dissenting views on the need for ultrasound surveillance of this person's liver?
Remind us what his fibrosis, did he have fibrosis?
I don't think I gave you one. Actually, it's minimal. Well, we did actually.
Minimal, okay.
Elastography, it was minimal.
Yeah. Yeah. I would favor continuing, but if you were thinking about not, I would use elastography as potentially.
Well, I will say that when studies have looked at this in large HIV practices, the number of patients getting routine ultrasound surveillance for liver cancer with Hep B is actually quite low. It's true of other clinics too, but it's an area just to emphasize. So we'll do another couple. I want to squeeze in two more quick cases. 31-year-old woman is admitted following a motor vehicle accident, has incidental abscess requiring IND. They call infectious diseases. The person is pregnant, early third trimester, active Hep C about 6 years ago, missed multiple visits, active opiate use disorder, not in treatment. Lab data below, Hep C is active, HIV is negative, Hep B is negative. So in addition to prenatal and opiate use disorder care, what would you recommend? 1, defer treatment until after delivery. 2, treat now with ledipasvir, sofosbuvir. 3, treat now with sofosbuvir, valpatisvir. 4, treat now with glicapavir, parbentasvir. And 5, defer Hep C treatment recommend to the obstetrician, delivered by C-section. So a number of things to unpack here, I think, for certainly. So this woman is in her third trimester with active Hep C, relatively high-ish viral load. The majority, but it's still pretty good spread, said defer treatment until after delivery. A good quarter, 24% rounding up, said C-section. Suzanne, I'll start with you since you spoke on this topic today. What will you do, and what are your thoughts on some of these other choices?
Yeah, I would start by saying that for women with hepatitis C, there's not an indication to use a C-section based on that that infection. I would also say that this is a really critical thing to discuss with the patient. She's in the 3rd trimester, which is, if you're going to treat her during pregnancy, that's the time to do it. The data that we do have has been done in the 3rd trimester. We have data with ledipasvir, sofosbuvir, and sofosbuvir valpatisvir. So to me, this is very much a personal question for that patient and what she wants to do. And if I had a patient who really wanted treatment, I would be comfortable treating her during the 3rd trimester. As we would emphasize, we often lose these people after delivery, and so it really is a critical time. So I think it's obviously, to me, a patient preference, but I'd be willing to offer her one of those therapies.
So any views, how many people would recommend the treatment given the lack, is there any value? I agree with the engagement patient. Ken, you look like you have thoughts on this topic.
Yeah, I mean, we're getting 2 to 4 of these a month, and so we're facing this on a regular basis. And we are generally recommending deferring until after pregnancy, pending data from the multi-center trial that's ongoing. We have referred patients to that trial, and most did not want to be in it, so we're deferring. I think we'll have more data soon. The trials that have been done to date are very small.
And I think one thing just to emphasize, and then we'll move on to the next case, is that the guidelines actually have a very progressive statement that says that this, sort of as Susanna pointed out, could be discussed with the patient, and although there's a paucity of data, something to consider. So it's a place where I think someone made the point earlier that the AASLD IDSA joint guidelines really leveraged, I think, the strengths of both societies and really produced a useful document that's living online. Not saying anything about other guidelines, but I'm just saying that it's a useful document. So this is, we'll do one more, squeeze in one more case. 54-year-old woman with well-controlled HIV, cured Hep C genotype 1, ALTs persistently elevated. In 2012, was referred, had the following parameters: taking efavirenz, TDF, FTC, liver biopsy, mild portal fibrosis, moderate fat, no steatohepatitis, drinking about 6 drinks on most weekend days, obesity with a BMI of roughly 35, deferred interferon-based treatment. In 2015, got cured, had a liver stiffness score of 19, a CAP score of 355, and on a follow-up visit 7 years later, still on treatment. The regimen's changed a little bit, no longer on efavirenz, but now taking cyclophosphamide, not TDF, new onset diabetes, recently started metformin, drinking 4 drinks a day on most days. The workup is below, A1C is 6, liver ultrasound shows steatosis, but no hepatocellular carcinoma, AST is 46, ALT is 35, the FIB4 is 2.64. So would you recommend a liver biopsy in this patient? There's concern about fatty liver disease, as we've talked about. So the question is, would you recommend a biopsy? And it's the yes, no, and maybe. So not a lot of love for the biopsy, 52%, but some are maybe. So we do have some card-carrying hepatologists here, people that actually do biopsies. And if I remember, Dr. Nagy trained doing biopsies a few years ago, just a couple years ago. And so let me ask the question, Ken. I'll give this to you since I talked to you last night about this question. Biopsy here, would it help us tell whether it's alcohol versus NASH? Would it help us to do a biopsy?
Me?
Ken?
Me, yeah.
We'll go.
I thought you were starting with Susanna.
No, I'm just picking on Susanna.
Yes, I think a biopsy would be helpful in this setting. I think the patient might be cirrhotic. We're not sure with that level of KPA 19, but fat also increases levels a bit, maybe not. And I think NASH, no NASH, as opposed to just fat. There's a lot of fat from the CAP, but I think a biopsy would be helpful.
And Jordan Lake, you're running a lot of studies on fatty liver disease, people with HIV. How are you deciding when biopsy helps in those, starting with FibroScan, but how are you working in biopsy into that from your HIV clinic perspective?
Yeah, so I'm not a hepatologist, for those of you who don't know, so this may not be the right answer. But in our screening cohort for fatty liver disease, I'm trying to sort of follow the guidelines for FibroScan for who might be next. So liver stiffness measurement over 7.5 or 8, some steatosis, and if I in the HIV clinic try to do it if it would change my management. So if they have access to some kind of treatment. And a lot of providers tell me, they are not even screening because they don't feel like that there's access to any treatment. Now that some of the clinical trials are allowing people living with HIV to enroll, if the person would want treatment and getting a biopsy would get them access to that treatment potentially, then I think you can certainly be more liberal with who you biopsy because you're trying to do something right for the patient. If your suspicion is high enough clinically, if they don't meet criteria exactly for a biopsy, then I think it's just discussing with the patient. Some people really want to know, and they can, if they can provide informed consent and they really want to know, why not? But
Susanna, thoughts on biopsy, or how often are you sending the fatty liver? You're involved in a study as well. How often are you sending those patients, and how receptive are your patients and their HIV care providers to the notion of a biopsy?
Yeah, I mean, well, that this has been a real challenge for us, actually. So one is generally the hepatologist will not consider liver biopsy in someone whose liver stiffness score is not above about 8.5 to 9. And then once you have a level this high in terms of a liver stiffness, they're often, again, resident to biopsy because they already think they have severe liver disease. So we refer generally once they're above 9, but that does not result in a liver biopsy in the majority of patients. And that some of that's patient and some of it honestly is provider.
Yeah.
I'll just add to that too. So in my healthcare system, since I was giving my personal experience, interventional radiology does all of the biopsies. And so if they get an order for it, they just do it. There's not a clinical assessment that goes with that. So it's a little bit of a different scenario.
And I guess we're running short on time, but I just wanted to touch, maybe each one of you think about management. There's a combination of, and we can go back, we don't have to put this slide up, but I just want to talk a little bit about management. The guidance talks about increased physical activity, talks about healthier diet, I think leaning towards Mediterranean diet, and actually mentions coffee, 3 cups a day, which I'm a little short, but I'll get a cup after we're done here. What are people's thoughts on how to implement that, and are you recommending coffee routinely? I was a little surprised to see the guidance actually for fatty liver.
Can I start?
Jordan, go ahead.
Well, the first thing, just going out of this patient, is I think the person has an alcohol use disorder, which I think needs to be addressed as the first and foremost thing. And to be honest, I would focus on that before the liver biopsy, because that's really driving, I think, both the liver disease and also other health risks. As far as coffee goes,
is the advice no alcohol for people with fatty liver disease?
With advanced fibrosis. With no fibrosis, I think it's fine to have some alcohol. And there's, in fact, some data suggests that it may, I think the data suggesting that it's reduces the risk of progression are questionable, but I don't think it significantly increases the risk of progression in people with mild fibrosis. But as far as coffee goes, there's really strong epidemiological data, and particularly from Asia, showing not only a reduced risk of fibrosis progression, but probably most importantly, reduced risk of liver cancer in both fatty liver disease and in hep C related liver disease. So yes, I get no support from Starbucks or any other maker of coffee, but I would, yes, we are promoting it for our patients, provided they tolerate it well. And actually, there have been now meta-analyses looking at other health benefits of coffee, and there's really little data suggesting there's much health risk to coffee.
Go ahead, Jeff.
Well, I have a quick follow-up question to the hepatologist. For the coffee, is that black coffee?
So what's interesting, they have done studies of different types of coffee. It does seem to be caffeinated coffee is better than decaffeinated coffee. And drip coffee, interestingly, is better than espresso. And it may well be that there's stuff that's coming out of we don't really know what it is. Most people think it's probably the caffeine in the coffee, but it's not totally clear. But you have to tell people this is not with sugar and probably not with cream. So milk is fine and sweetener or nothing.
So we'll leave it there. We've run short on time. I want to thank our panel for a wonderful discussion about some interesting cases, and thank the folks for joining us at home. So thanks to our panel. And then I'll make just a few closing remarks to wrap it up. For those of you online and in person, remember the post-conference CMA survey evaluations coming to you sometime early next week. You'll get these reminder emails. Please fill that out. We really do listen to them. You can even tell us what kind of music to choose. We want to hear from you. And then you'll hear from us again in 2 or 3 months following the conference. And this is really important. We want to know how our education has changed your practice. If it hasn't, tell us that, but we hope it has made a meaningful difference in the care of your patients. That's why we do what we do. There's the archive, so send your friends and neighbors to the archive. In April, it should be up and running. Makes for very good streaming on the weekend. Maybe skip the Netflix series and watch the OPMAN XXXI archive. And another shout out to our commercial supporters. We're really grateful for these independent educational grants from our supporters and really value their partnership in putting this on. So now we're going to break in person for the roundtables. You can go to 2, 30 minutes each. You've got Hep C challenges with myself and Susanna Nagy, Hep B and D with Debica and Jordan Feld, Fatty Liver with Ken and Jordan Lake. And then Glenn is going to pick up where he left off with burnout and substance use disorder, different rooms there. For the virtual attendees, we really appreciate you committing a better part of a Sunday and a Saturday with us. And we look forward to meeting again with you all next year for OPMAN 32. Thank you.